top portion of the funnel. Listening, doing a little bit of learning, sharing some best practices. Today is all about trying to narrow that focus. And what we'd really like to get down to today are the details of potential recommendations for accelerators of care coordination. Accelerators at the state level and accelerators at the regional level. You've heard Jack just talk about a piece of today where we're going to spend time talking about data. We spent a lot of time talking about data, but it's time now to really define that and to understand what we can do here in the state to get access to exactly what we need to accelerate care coordination. We're then going to shift gears and talk about that homework assignment, your ideas, statewide accelerators, regional accelerators, to make certain that we can do the best we possibly can. There is funding available. What I'm going to ask Jack to do is to push us in that conversation to be as concrete and specific as we possibly can. So we've been talking about things like data and care planning and behavioral health, which is helpful, but we now need to get specific. Exactly what is it? The 2 or 3 or 4 things that we collectively want to recommend back to the HSCRC as the most important things and next steps that we could take. So that's going to be our challenge. Jack will push us for specificity. What we hope to do today is to get enough ideas out on the table that we can then chew on them and make some important decisions as we head into the next couple of meetings. So that's what we've got in store. Laura, thoughts?
No additional comments. I think you summed up where we hope to get by the end of today's meeting. I think, moving forward, we're really just trying to get down to the details right now and what will this all look like, and as to the homework, what are we going to keep at the state level, and what are we going to move down regionally and even locally. So we thank you all for your time today.
And just one last comment, our greatest challenge is going to be to stick to the agenda. While we have extra time, we are going to use every second, every second of it. So with that, maybe we can hand off to Donna, please.
And will we hand off the slide clicker? Sorry. Yes, we want to get past that document to the, there we go. So I am going to go quickly through this because we have an agenda, but I've been to a number of meetings with the physician work group and with physicians across the state, and now with you all saying, well, where is it that we're heading? So what we've done in this slide presentation is to outline where we think we're heading, based on some of the conversations with you, as well as where we think we need to go to accelerate the process of care coordination and clinical improvement, because that is the phase of the work that we're in here now that we have gotten. All of the hospitals on global model and gotten the payment system geared up to do what we need to do, now we really need to focus on the clinical side. And we need to do that not just at the hospital level, but recognizing that this really is a partnership. It's a team effort. It's a partnership effort with the physicians and the practitioners in the state, the long-term and post-acute care providers, the community health organizations, and others as we move forward in this journey. And we need to bring the resources to bear that are available from all of those efforts. So we have resources in accountable care organizations and medical homes in the state. We have a new resource in the terms of Medicare care management fees that we'll talk a little bit more about in a minute. And if we can bring that resource to bear in this process, it can really help align efforts. And we don't have a medical home in Maryland, but this care management fee program really has the opportunity to bring primary care physicians into a medical home model for Medicare patients. So that's a really big opportunity with those Medicare care management fees. And then we have had, of course, the state and local entities focusing on the health improvement process and bringing that to bear. And finally, the health information exchange, which is such a critical part of the interoperability that we've been talking about. And of course, this is all for the benefit of patients and consumers, and focusing on how to get them engaged in this process and really working with us and us working with them. What we've talked about is really focusing on Medicare initially. In our view of the data, 2/3 of the high needs patients that are using hospital are Medicare patients. They have high numbers of chronic conditions, and addressing those conditions is essential for contributing to cost containment as well as better patient outcomes. And our Medicare savings test requires us to get reductions in utilization beyond national progress of 1.5% per year. So there's a very strong rationale for us to start there. And we can use the same approach for other populations, but we'll need to work carefully through coordinating those with the commercial carriers and with the Medicaid MCOs. And just to kind of put that in perspective with some additional statistics, we've already looked at some, but from a total cost of care for Medicare, 14% of the patients have 6+ chronic conditions, and that 14% of patients drive 50% of the cost for the Medicare program. So we need to start focusing on that. We need to start by focusing on some of those patients as we look at our high needs patients and high utilizers. In an earlier meeting, as we started looking at them, we looked at hospital patients that had 3 or more admissions, and that was about 2/3 of our high utilizers at the hospital, and they account for about 1/3 of our hospital utilization dollars for inpatient and emergency room. And it was about 27,000 people. So going back to bringing the provider groups together, we have an opportunity to really address common interest in this process. The hospitals have a very strong interest in, now with the Medicare has introduced a care management fee effective January 1 that can be paid to physicians who provide the required services to patients with 2+ chronic conditions. It's $40 a month. That's $500 a year for those of you without my advanced math degree here. And and if you take 200 patients for a practice, and it's actually, in some of the examples, you can actually look at maybe as many as 500 patients per doctor that could qualify for that fee. But if you take 200 patients, that would be $100,000 of revenue per primary care physician. That is a really substantial amount of funds that can be helped to bring care coordination into a primary care practice. So the financial opportunity is real. If we ultimately ended up with, and the JAMA reported that, actually it was the New England Journal of Medicine, reported that 60% of the Medicare patients would actually qualify for this service. So start multiplying those numbers out, it gets very large. But to make it really easy, for 50,000 patients, it's $25 million. And easily, you could see that as many as 250,000 patients in Maryland could easily qualify for that program. So the numbers, the opportunity to bring that money to bear in the primary care, or the community-based practices, it's not limited to primary care, but the community-based settings is very significant, and it's very real, and it's now. So it is something that we need to think about as something that was closed off to us before. We didn't have a way to get the medical home model paid for in Medicare, and here's the opportunity to get it paid for. So I just wanted to bring that to your attention as we move through this conversation. And also, we are started on, but it's not the focus of this work group, but we're started on continuing efforts to develop incentive approaches for gain sharing and pay for performance that will allow funds to get deployed from the hospital in the terms of pay for performance to community-based physicians, as well as for hospital-based physicians through the program that MHA is pursuing. But that will, more details soon. So at a high level, what we would really hope to be able to focus on coming out of this process is starting with those very high needs patients. We envision that many of those high needs patients would end up in individual case management, and this will look very much like the Kaiser Permanente chart. You all said, what does it look like? So we would like to think that we would have a small group, and small relative to the total population, of high needs patients in individual case management. And we really need to also focus on addressing modifiable risks of the individuals with high chronic conditions and at the risk of becoming high needs or high use patients. A lot of the effort here will be trying to get out of the gates with the highest level of patients that need the individual case management. The resources and the requirements to execute on the modifiable risk require a very significant ambulatory strategy, and we actually hope to discuss that at the next meeting and not today. So that more to come at the next meeting. So just kind of roughly, what do we see as the number of people that are involved in these strategies? If you look at the high need use patients, we're focused on something in the 3 to 5%, so 25 to 40,000 people at the top of the pyramid that would need individualized case management and care coordination. Then as you work your way down, you'll see that there's a lot of people involved in addressing identifiable risks. So 240,000 Medicare beneficiaries, chronically ill or at high risk of or at the risk of being high use. So that is another area of the pyramid that we want to talk about as we extend our conversation about the ambulatory strategy next meeting. So the key strategies are to make sure that we're able to identify who these individuals are, to be able to stratify the patients, to customize and focus our approaches. For the highest risk patients, initially something in the 40,000, 25 to 40,000 range, we would want to perform assessments, individual assessments, develop care plans, develop individualized case management, and develop systems to rapidly be able to respond rapidly to changes in patients' conditions to reduce avoidable use. And then also to implement approaches and interventions to reduce and modify risk and integrate care across provider settings. And this is really where we get back to, and I get to talk to Dr. Loftus quite a bit about this issue as well, but hammering on hypertension and hammering on diabetes control and hammering on the modifiable risk that will keep people from moving to that top red pyramid, the top of the pyramid. So, and then to monitor the outcomes of what we're doing and modify and keep driving this approach to produce better results for our patients. So that's really where we see that we're trying to head with you. And that's what we're trying to document from the conversations that we're having, and we'll be testing whether this is an accurate representation of the strategy that you have, because at the end of the day, it is your strategy. What we see out of this is really a need for a lot of collaboration. The high utilizers with the larger number of admissions are more likely to receive care at multiple hospitals. So there's a need for collaboration at the hospital level. And then when we start into the physician side of it, and we need to start into the physician side of it, it's even a bigger issue. So the median Medicare beneficiary saw 2 primary care physicians and 5 specialists. So that was the median. These are not the median group of folks. So you can just take that this high utilizer group is seeing even more physicians. So there's a lot of need for collaboration. So with that, we'll turn back to Carmela to set some of the stage for where we're headed later in the conversation today.
Thank you, Donna. So I'm going to take you through what we hope to achieve by the end of the day, and then we're going to take a step back and start with an issue around data. Let me start. So with a U, opportunities, our objective today, what can we do to accelerate these efforts? And I want us to be mindful, I think, as we proceed with this conversation. We have come over the last couple of meetings to appreciate there is a lot already going on. There is a lot happening in the field that even those of us around this table are not aware of. So I have sometimes said, if we were coming over on the Mayflower, there might be some things that we do. We've got to be cognizant of what's already out there, but we're looking for the accelerators that we can layer on top to really begin to move our efforts here in the state of Maryland. As you can see at the bottom, and just a reminder, $15 million was set aside in the budget bill last year. Those are dollars to be spent in this fiscal year and available for this effort. What can we do to accelerate care coordination at the state and regional level? Some $1 to $2 million of that will be allocated for an effort that is underway to initiate RFPs to make some awards at the regional level. But our planning here is very concrete. Not only are there ideas, we actually have some funding that would be available to get some of these ideas started. So that's really where we'd like to get to today. This is my dream. This chart, if we could come out with one thing from the activity of this work group, it would be an ability to fill in this chart, to say, what are the things we can do to accelerate care coordination? Which of those are best done at the state level, the regional level, with the assumption that everything else is left at the individual hospital or local level. So our hope is today we'll begin to play around with this, populate this chart, but we will be giving this back to you, filled in based on our conversation today, and then we can have more discussion about whether things need to move around and then beginning to prioritize. We may end up today with a list of 100 activities. That would be a good day. I don't know that we'll get there, but we'll want to come back and prioritize these to pick the critical few. So where we're going to be headed later this morning, and thank you for doing your homework. And if you didn't, take a little piece of paper right now and you can fill in your ideas. What are the 3 most important activities that we could do to accelerate care coordination at the statewide level? Same question at the regional level. We will be asking for your input. And we'll come back and put these ideas back on the screen. These are just ideas designed to prime the pump of our collective thinking. But here are some of the things that we might pursue on a statewide basis. We're going to start our discussion today with the issue of Medicare data acquisition, but a whole number of things. Mark, I think the last meeting, you were saying how there really is no gold standard for determining who's at high risk. That may be an area we come back and say the most important thing we can do is to do some research. I'll use that with a small r. But let's get some great brains in the room to say who's doing good work around patient stratification. What is the gold standard? Can we create that and share that with organizations in the state? But you can see a whole list of ideas here, potential things we can do at the state level. And similarly, some ideas for regional collaboration, things that might kickstart efforts at the regional basis and at the regional level. These are ideas we'll come back to in our conversation and hopefully be able to put them back up on the screen. The idea is, do any of these resonate, but more important, what are your ideas? So that we'll take those back and begin to populate this chart. So that's where we are. The to be continued is our next meeting. We are and have been somewhat hospital focused as we've proceeded. The next meeting, we really want to focus on care coordination from the ambulatory perspective. We're going to have an opportunity to hear from some physician leaders, experiences, and we really want to come at it from that perspective at our upcoming meeting. So we can continue to populate this 3-column grid. So today may be more of an inpatient focus, but please feel free to throw any ideas you may have out there on the table. So with that, if I may turn it over to Jack. Again, we're going to split the morning into 2 pieces. The first piece, data, data, data. What do we mean by that? What can we acquire? My own personal view, this is a tremendous opportunity. How do you say this? Securing data from the Centers for Medicare and Medicaid Services is extremely tedious and difficult. You're going to hear a little bit about that. But we think this may be a great opportunity for us to collectively pull that together and begin to understand the broader picture of what's going on in health. So, Jack.
Well, good. Thank you, Donna and Carmela, for getting us going. And let me just reiterate, we will have a thorough discussion of this in about an hour. So here's how this session is going to go. Deborah Gracie, to my right, is going to lead us through the presentation. I'd like just to take a second and introduce Dr. Art Jones, if you could. Dr. Art Jones is with HMA and has contributed a good bit to this, a lot of good thinking to this presentation. And Art, anytime you want to jump in during the day, and please do. After Deborah is done, I'm going to call on Dr. Amy Boutwell to my left. Many of you know and have worked with Amy, and she's affiliated with Massachusetts General Hospital and Newton Wellesley Hospital in Boston, came down again for this meeting to share ideas. So she'll say a few words and tell us a little bit about some interesting things going on in Boston that are very pertinent. And then I'm going to give my colleague Tony Rogers by phone a few minutes, because he has been a leader at CMS before coming to HMA, to share any of his thoughts, and then, of course, throw it open. So, Deborah.
Thank you. I appreciate that, Jack. It's my pleasure to be working with you today. Thanks for the opportunity. Jack mentioned Tony Rogers. He was actually the Deputy Administrator at CMS in the Center for Strategy and Planning from 2010 until 2012. He was one of the contributors to the work I'm about to present to you. Dr. Art Jones was the CEO of a very large FQHC in Chicago for many years, and is now helping states, FQHCs, companies to really integrate care all over the country. Dr. Greg Bichon, who is also on the phone, a practicing physician who has also, he's an expert in technology and data. He also contributed to this piece of work, and he has helped many entities of different kinds to figure out how to put technology solutions in place to integrate. So I want to acknowledge all the people. I'm representing a lot of people's work. Megan Kirkpatrick, I should also mention her, did a lot of very deep research for us because we wanted to make sure that we were looking into details. And because, you know, a lot of times in this kind of work, the devil is in the details. So, so thank you to her as well. Okay, so Medicare data for high-value care. Okay, so we're on that slide. Okay, great. So the purpose of today's discussion is to talk briefly about the value of Medicare data for care coordination, to recommend a game plan for obtaining and using that data to create high-value care in Maryland, and to gain consensus from this group on the next steps. So high-value care, there are many components that are needed for creating high-value care, and data is only one of them. So one of the things that we always tell our clients to do is be careful. Yes, data is extremely important, but once you get that data, you need to link it and manipulate it and make it usable, and then you actually have to use the data. And the people in the provider community and the state community, you know, they need to know how to use that data, and they need to be motivated to use the data. So data is important, but it is only a piece of the puzzle. There are multiple types of data that can be used to support high-value care. The claims, encounter, and billing data, the kind of data that we would get from CMS, you know, on the Medicare patients, is important when you're trying to get a holistic picture. It includes billing diagnoses, length of stay, insurance and payers, the billing provider, immunizations. It includes a lot of data. This kind of data is particularly useful when you're trying to do any kind of attribution, because when you look at, for instance, Medicare data from CMS, you can see the entire picture. Those slides that Donna and Carmela showed, where people are using multiple hospitals, multiple specialists, multiple PCPs, any one of those providers only sees their picture of the puzzle, and it's not a complete picture. When you use Medicare data, that's where you really can understand everything that a specific patient is doing. Where are they going? Who are they seeing? What is happening with them? And that becomes important when you're trying to get into the care coordination efforts that you're pursuing right now in Maryland. Pharmacy data. You know, pharmacy data is, you can get that from Medicare. You can certainly get that from CMS. Sometimes pharmacy data is harder to get at the individual health system level. But again, it can be used for things like risk stratification, because many times the medications that people are taking is an indication of how sick they are and how high risk they are, and things that are working right and things that are not working so well for those patients. The third kind is structured data. I'm sorry, Jack, are you trying to message me? Okay. Okay, just want to pay attention. I welcome anybody to jump in here as I'm talking. Okay. Structured clinical data. So this is where, you know, you don't necessarily, so claims data is important. What Medicare knows is everything that the patient is actually doing. But what Medicare doesn't know is what the doctor has suggested that the patient does, that the patient does not do. For instance, the prescribed medications. Okay, so there might be a list of prescribed medications that a doctor has that is not at all what the patient is going to get at the pharmacy. And this is an indicator. This is another indicator as it relates to care coordination. It's, why is this person not taking their drugs? Why are they not taking these medications? Let's solve it, right? Rule-based tasks and episode management. So there's a lot of things. You know, the problem list. Medicare data doesn't have that. The provider community knows that. All right, and then there's non-structured. That's like direct messages and patient-specific goals and action plans. So usually a well-thought-out care plan has things in it like the motivators for this patient, because patients are people, and there are things that are motivating them. They don't have a ride. They can't afford their medications. They don't feel good when they take that medication, but nobody listens to them when they tell them. So there are, this is about the person, and so there's these 4 levels of data that in the ideal world would be employed to actually put together a care coordination plan. Now, I mean, you all will be making decisions about what kind of data is used for what as you put together and set your direction and put together the details of what you're about to embark on. And sometimes you have to take baby steps towards the ideal world, but there are certainly many ways of looking at data for the purposes of care coordination. Okay, next. Oh, you're just right on. Thank you, Matt. All right, so right now, Maryland has Medicare data, but it cannot be tied to a specific person. You can take a number that and you could say patient XYZ249 has all of this going on, but we don't know that that patient is Mary Jones. And that's a problem when you're trying to take that data and make it apply to an actual person. So beneficiary-specific Medicare data, where we actually know who the person is that's tied to this Medicare data, gives us a more holistic view of the patient and more opportunities to coordinate care. And this is basically what I was describing earlier, the beneficiary information, professional claims as well as institutional claims, risk scores. Medicare puts a risk score on every patient that changes as diagnoses come in on claims. So they have what I would consider a pretty sophisticated way of looking at, yes.
So in terms of talking about Maryland,
Use your microphone so folks on the.
sure. It's probably good to say when we talk about Maryland, you're referring to the state, but when you actually talk about providers within Maryland, particularly as we talk about ACOs, that ACOs have patient-specific data that they're accessing today. I think that's more to come on that later, but the state doesn't have access to this today. I think that's important to distinguish.
Okay, thank you.
Right, we do have access to Medicare data, and it has medical records numbers on it and things that are identifiable, but we don't have names and addresses, and we don't have permission to use it for care coordination. So that's really where we need to drive the conversation forward. So we don't have the permission to share it back with providers for coordinating care. And we're going to get into that whole process now. So if you want to hold your questions on asking them how we're going to go about it, that's where we're about ready to drive through this conversation.
With the Medicare data, but I can wait in terms of comments if you.
Why don't we lay it out for everybody? Not that we'll ever get to level set today. I'm going to be like the last one. Understand that? Well, we're trying hard. Why don't we level set everybody, and then we can dig in. Thanks.
Okay, great. So the Maryland All-Payer Model Agreement allows the demonstration to request individually identified data. So you do have a door to that data. The language in the contract says that over the performance period of the model, that CMS is willing to accept data requests from the state of Maryland or its agents for data necessary to achieve the purposes of the model. So care coordination will need to be added as a purpose for the model. Such data could include individually identifiable health information such as claims level data. All such requests for individually identifiable health information must clearly state the HIPAA basis for requested disclosure. In our discussions with Tony Rogers, who I mentioned at the beginning of this call, he was very much involved from the CMS end with working on the demonstration projects. And care coordination is a valid HIPAA basis for individually identifiable data. You just have to do the work that it takes to describe what exactly you're going to do with it. And that's what we'll talk about next. So the request process. You would work with the demonstration project manager, establishing continuing discussions and negotiations. Some initial communication is in progress. Donna and others have had some preliminary conversations with the project manager of the demonstration project, and they are showing support for what you are embarking on through this effort. Donna, I don't know if there's anything else you want to say about that at this time, or?
And we're having regular updates with them on what we're trying to do with care coordination and physician alignment and with the top of the administration there. So they're very interested and will help us in any way they can.
Then so these communications are going and would be ongoing. We would provide that project manager with a solid plan and basis. So exactly what are we going to do to coordinate care? What is the specific data that we need to support those efforts? Who in the delivery system will have access to what data and for what purpose? How is the data going to help the delivery system to help the patient? Why are we expecting these processes and this data to make a difference in the care of the beneficiaries? Any of you who have worked with CMS know that CMS is going to protect the beneficiaries. So they're going to give data to people who they believe will use it for the good of beneficiaries. They will not give it to anybody who they think will not have a specific purpose that will help the beneficiaries themselves. That's their mantra. That's how they write everything. That's how they do everything. So it will be important for us to work through that. Once we amend, so working with the project manager, we would amend the demo and include these care coordination activities, and then the data use agreement follows. The data use agreement basically says that data can be shared for the purposes of the demonstration project. When you change and add to the purpose of the demonstration project, then the data use agreement covers that. And of course, that's a very simplified version of it. I mean, there's a lot to that, but it is how it works. And it gives us the motivation to think about what exactly do we want to do and answer all these questions and work with CMS to get this beneficiary-specific data. If that doesn't work, even though we would expect it to work, there are other approaches that we can consider, such as looking at organized healthcare arrangements. I don't want to spend a huge amount of time on this now because it's our expectation that doing it through the demonstration project is going to be the best way and the fastest way to get it done. I don't know if anybody else wants to comment on this one at this time, or you want to wait until we get later in the conversation. Okay, good? Okay, all right, great.
Right, before we go, can I ask a clarifying question? So the requester, we had conversations before. I thought I understood it needs to be a provider, or it can be the HSCRC on behalf of the providers, or I'm trying to get a sense of, do all providers need to be on board in order to get the full complement of what we think we need?
It's a conversation that we'll have to take back up with CMS. So it's complicated because we signed the agreement. We're not a provider, although we think we're about to be classified not as a covered entity, but a quasi-covered entity. But the state law was passed that binds hospitals to the demonstration. So we have a state law that says hospitals are bound to the demonstration. So that's really kind of where we think we're trying to head with this. And we've had, during the negotiations, we had a lot of discussions with CMS about this topic. So it won't be the first discussion, but it is. We describe getting data from CMS as like putting a paperclip in your eye. It's a very painful process, and they do. We have to know exactly what we're going to do with the data, and we must protect the beneficiaries and respect patient choice and patient rights when it comes to data use. So that's why we have to drive through a very specific process, and we'll have to alter the road a little bit depending on our conversations with CMS. But I think there's at least we had a lot of negotiation to get language into the agreement, and we're hoping we can move it forward.
And if I could just underscore, this is somewhat unplowed fields here. CMS sounds as if they are interested and willing to work, but as Donna's just underscored, the waiver contract itself is between the state, the Department of, the state and the federal government. We are all entities participating. There's some clarity that's still needed before we can answer your question, Debbie.
So it may, in the end, require all of the hospitals to sign data requests, but that's not unheard of. We did that with bundled payments and ACOs, and so these things can move. We will find a strategy to move forward once we know what that strategy is.
So, no, go ahead.
Rob, go ahead.
I was just going to say, on the one hand, hi, it's Rob Cohen, and I was just going to say, on the one hand, yeah, this is absolutely complicated, and figuring out how to get through the gate is a complicated process. At the same time, I think we take the position that there's in the range of dozens of models that CMS has implemented where they, in fact, have given the data to organizations. There are many hundreds of organizations that have gotten the data related to many millions of beneficiaries, and we are analogous to those dozens of programs and hundreds of situations. And so I think if we just keep thinking about that it should be doable. It would almost be silly to think that it wouldn't be.
Yeah, I had two things. One, if it's going to be complex for the hospitals, I guess that means it'll be more complex for any community or outside organization that was interested in doing it as well. I think that probably goes without saying. So it seems to me that if we're going to try to do something with regards to care management, and we know it's going to be hard to get the data, and we have to have the data to do it successfully, that it kind of pushes us towards standardized approaches with regards to this. And I know there might be some tension around that, but if we can, it's just something we need to think about, because if we all try to do stuff, if I take the 3 ACOs that MedCai has an interest in, and I'm doing the care management with that data in this way, and then you're doing it another way, and then I want to get more data, and you have 80 organizations coming to the HSCRC asking to help get data from CMS for different types of plans, it's going to create a lot of inefficiencies and confusion. So I think it pushes us more and more to some type of standardization. It was just kind of my thought while I was sitting here.
Can I ask a clarifying question? My understanding, we wouldn't be asking for, if you will, the hospital data. The whole idea is to get all of the Medicare data, which in theory, we have to figure out a way to make available to all of the care partners and providers. Here's where we get into the legal aspect, I'm going to guess, in terms of who gets access. But once we have the Medicare data, then it's figuring out who can access.
Well, and it's not only, it's what exactly will be done with it, okay? Because it's not like as if we're going to say, okay, here's the data, everybody request what you want. No, that's not it. It's what specifically. For instance, if we choose to do some kind of attribution, which we'll talk about here in a second, and we say we're going to identify the high-risk patients, and we're going to determine which provider, whether it's a physician, a hospital, a care manager, needs to be aware of that high-risk provider, and we're going to push that data to that provider. Once we figure out how this all looks, and there's a lot of details, okay, but as an example, that data gets pushed to that provider, and that provider is expected to get that person into care management. It's a high-risk patient. We're identifying, we're being proactive in identifying them for you. That's a very specific way that we're going to use the data on behalf of the beneficiary, and it really doesn't involve 80 people requesting 80 things.
I see Amy
Yes.
next, and then Lori, and then I think we're going to try to move back to the presentation.
So we have some experience with the Medicare data because of the CMMI grant that we received 3 years ago, and so we've been sending all of our beneficiaries from prior to 2000 up through 2009 to Medicare. We've requested all of the data sets that you're speaking about, as well as data sets from quality data sets on home health and SNF, so the OASIS data, and also the RUG data to understand quality. There are a number of specific questions that can be answered, as you know. There's the issue of pushing data out to a provider and say this is a high-risk patient, you should do care management. There's the issues with the data set itself. It's very complex, as you know. Unraveling it and putting it into tables that can be used appropriately. They do not send patients who have substance abuse issues in any of their diagnosis codes. Some of these things are limiting factors. But the things that we can do in terms of the questions we can answer related to care coordination, Donna, I don't know whether my email went through to you last night or not because I can't find it. But some of the kinds of questions really do have to do with, of all of your beneficiaries, how many of them actually did complete a post-discharge appointment and have an EMN code, how many of your patients did have post-acute services through home health, through hospice, through SNF, what are the SNFs, which of the SNFs did they return from, are we shifting costs from inpatient to outpatient, and what are the ambulatory costs associated with that. These are some of the longitudinal things that we can see, as well as back to ED visits and where they go and those kinds of things. So it is pretty significant, but it is a very difficult data set. And then being able to link it back to the organizations that have these patients and who they are the primary providers for those patients, and then being able to use that in our own data sets to really understand and link them to the activities that we're doing makes it even more complicated, especially with the data use agreement. So I just wanted to comment on that.
I appreciate that because I'm going to address that on the next slide.
Okay.
It's exactly.
I think Lori, and then we'll go back to the slide.
Thanks. I just wondered if we might look at, we do have a chronic health home operating here in Maryland. It's blessed through CMS, through the ACA, and it's been very successful in terms of care management. Unfortunately, we can't do the Medicare onlys. We do Medicaid, and we do the dual eligibles as part of that. And one of the ways it has become successful is we use a patient registry that actually gets the Medicaid claims data directly into it. So we know if somebody has gone over to this provider over here, or, of course we use CRISP as well, and we can set up actual risk categories. So if someone has not had their meds filled, red flag, something's going on. Just like you suggested, you can look at these things and tell that somebody's heading for a bad outcome. Is there some way that we could look at that as a model for how we might approach Medicare, so that I know we would love to expand this to Medicare-only patients and have access to the Medicare data, because that we're working in the dark if we don't have that. So I just wanted to throw it out there because apparently CMS was okay, and we had to do a lot of talking with the state, but they became okay. So maybe there's a model to look at.
Yeah, thank you. That's great. And if I could make a request to both Amy and Lori. Oh, I'm sorry. No, that. If I could just make a request to Amy and Lori, and any of the other of you as the day goes on, if you have a link you can send me, or a presentation for whatever is public, some of this may be confidential, because we are trying as part of our initiative to do not an exhaustive inventory, but a look at several of the promising initiatives already underway in Maryland. That would be most helpful. I can get you my business card, or before the end of the day I'll give you my email address, but that would be most welcome.
And I actually have a different form of punishment, which is to actually ask you to help us with the data use agreement, and so that you can tell us exactly what you need, because that's really one of the hardest things to do. So you'll learn what you didn't ask for, and you know what you want in the next time around, and you know what you want. So we will put you to good work in writing the data use agreement.
Yeah, thank you. Deb.
Okay. So those are all great comments, and thank you for them. Okay, so what should we do now that we've heard all this? What should we do? Here's the recommendation that is being put out on the table today. Develop a detailed plan to create a collaborative care coordination initiative for fee-for-service Medicare patients. Identify, obtain, and organize the data needed to support the components of the initiative. So what this would involve is to develop the detailed plan for the care coordination of high-risk patients, identify, and each one of these I'm going to spend a few minutes on. I'm doing the funnel, okay? This is like the big picture, and then I'm going to spend time on some of the details for each one. We're going to develop the detailed plan for the care coordination of high-risk patients. This is the recommendation. Identify the data needed to support each component of care coordination. Create a detailed request to CMMI for Medicare data to support care coordination. Not that Medicare data is going to be the only data needed for that. There will be other kinds of data, and we'll talk about linking and manipulating and making it usable as we get deeper into this. We'll identify implementation plan, budget, and resources, and identify and hire a vendor to manage and distribute the data. So let's spend some time on each one of those. All right. So developing a detailed plan to coordinate the care of high-risk patients. The recommendation is for the following components of that plan. The capability to attribute members to providers. So if we want somebody to take accountability for care management, we're going to have to figure out who that is and let them know that they're it. So that's where the attribution comes in. Set up a risk stratification process that identifies patients who should be in care management program based on their risk level. The capability to inform providers of patients who are eligible for care management. So it's the same thing. There's a percentage. I mean, Donna mentioned 14% of the Medicare patients drive 50% of the costs, right? So we're going to want to figure out the risk levels. How many risk levels do we want? What is the criteria that's going to be used to set those risk levels? What is the data that we're going to use? And again, maybe it's a combination of Medicare data and other data, but Medicare data would be the most comprehensive data that we can get our hands on in combination with the other sources of data. Thirdly, we would want a care plan for patients and care coordination with the capability to share among providers. So we're going to want to figure out how to create a care plan that can be shared with other providers so that we have a more holistic plan around these high-risk patients. And number 4, we're going to want outcome data collection and analysis for the purpose of continuous improvement. Now, there is some analysis that's going to happen to do each one of these components. But in addition to the analysis, you know, how do we determine risk? How do we determine attribution? We're also going to want to look at outcomes data in aggregate and cut different ways to say to ourselves, what if this is working and what if this needs help? How do we get on continuous improvement so that as we learn, this is emerging. I think Carmela said that. This stuff is emerging. There is not a right answer at this point in time. So we will want to be able to look at the data and think about what we're doing and make it a continuous improvement effort. Okay, the second one, identify data needed to support each component of care coordination. We're recommending that we evaluate best practice for the data needed to support the components of the care coordination mechanism. So there are multiple models. I think Rob said dozens, okay? And I don't know if it's dozens, but there are multiple models for attribution. There are multiple models for risk stratification. There are multiple models for care plans. So we're going to have to think about it and decide, what do we want to do? How do we want this to look? And what is the data that's going to be needed to support that, whatever that is? We'll want to develop a strategy for data sharing that addresses patient-provider relationships necessary for provider collaboration and care coordination. So again, we're going to have to think about who needs to know what and how are we going to share it. We're going to need to consider all types of data, as I've been saying, the Medicare data, the hospital administrative, discharge, and transfer data. Chris has some data that is more real-time than what Medicare has. Doctors, hospitals, many people have data that's more real-time and that doesn't show up in that Medicare data, as we talked about earlier. Some of the data, as this lovely lady mentioned earlier, that you get from Medicare is extremely hard to use, and it's not timely. And so we're going to have to say to ourselves, what is the best place to get the data? Where's the most timely data? Where's the most usable data? How are we going to link that data, make it usable, and then actually use it? Okay. Create a detailed request for Medicare data to support care coordination. So once we do all that work, and as we do the work, we will be talking, we recommend that we will be talking to the CMS project manager for the demonstration project, and we will be describing to them and working out in detail a description of the purpose of the data. So that's where we'll say, we're doing attribution. This is the data that we're going to use for attribution. This is where we believe it needs to come from. This is what we need from CMS as part of that formula. This is who's going to get that data. This is how the delivery system's going to use it. This is how we're going to share it, and this is how we're going to make sure that it's protected. We will be requiring them. I might have said every bit of this just now, did I? Yes, I think I did. Okay, so there you go. All right. Identify implementation plan, budget, and resources. So what I just described is no small piece of work, right? Everything that I just described is going to require some focused effort. So we recommend that a work plan is developed that will identify the resources needed to support the efforts, consulting resources, technical vendors. We'll need to identify potential funding sources and strategies and develop a timeline for implementation activities. All right, identify and hire a vendor to manage and distribute the data. So as we've been saying, CMS data is not easy to use. There's a massive amount of it. You have to manipulate it. You have to link it. You have to do all kinds of things to make it usable. You already have some CRISP data, which can be tied to it. I mean, there's all kinds of really interesting things, but there is a lot of work in taking all of that, linking it, and making it usable. So we're recommending that we hire a vendor to manage and distribute the data, manipulate and link Medicare, CRISP, clinical, and other data, act as the central repository for the Medicare data, have the capability to push meaningful, actionable data to the provider community, and maintain privacy and security protections. You already have the CRISP organization, and I think that will be, a very important part of this discussion. They're already doing some of this linking and manipulating, and so again, it'll be part of the discussion. Okay, so I'm going to turn it back over to Jack, but before I do, because we're going to, need to have some discussion. So what you have here is like a high-level direction, right? And what this high-level direction includes are these key things. So we develop a detailed plan, and this is the recommendation we're going to try to get consensus on today. We're going to develop a detailed plan for the care coordination of high-risk patients. That's a direction. There's lots of details, but we can say to ourselves, yes, we think we should do that. We're going to identify the data needed to support each component of care coordination. We're going to create a detailed request to CMMI for the Medicare data that we need to include with other data that we have. We're going to identify an implementation plan, budget, and resources, and we're going to identify and hire a vendor to manage and distribute the data. That's what we'll be trying to get the consensus on today. So with that, I'll turn it back over to you, Jack.
Thank you, Deb, for very thorough and also very concise presentation. And here's what we're going to do, and we're pretty much on schedule. So I'm going to turn now to Amy to offer a few of her thoughts in reaction. And then I'm going to give Tony just a couple of minutes if he wants to jump in by phone. Then we're going to push for consensus, get all your ideas and suggestions and modifications. So, Amy, the floor is yours.
Well, thank you, Jack, and thank you for walking us through that. It was really clear and painted a great picture. Jack, if I might ask permission to defer what I had wanted to share until the facilitated discussion at 11 about what activities at the local and state level might we do in addition to moving forward on this plan. I think I could best contribute there.
That's request granted. Thank you. And so now, just let me pause, since my good friend Tony Rogers started on this call at 6 a.m. And is also knows a lot more than I do about all these. Tony, if you're on, if you would like to add a thought or two, your experience with data use agreements and modifying them, and rather than seeking a new one, or any quick thoughts that you have you'd like to share, please do.
Well, thank you, Jack. Can you hear me?
Yes.
Oh, great. So the sun has finally risen here in the west, so thank you for sending the sun our way. In the discussion, I think you have a good plan of attack. A couple of points from a CMS point of view, having been on the other side of this and having the data people report to me and having to fill data requests, et cetera, as well as on the demonstrations. The first thing you should focus on is the demonstration. You have an existing demonstration, you want to modify that demonstration. That's key. Once that is clear, once everybody agrees to how the demonstration will be modified, and you have to remember this will be added to your evaluation, then the data will follow. That data is not going to be a significant barrier, because the way that the demonstration is written, once the demonstration is modified, by extension, you are authorized to use the data per what the demonstration agreement is. So it's going to be really important to put together your plan for care coordination, how that will be managed and operationalized, and how the data will be used and protected and secure in this care coordination approach. The other thing I can suggest you think about is that there are other demonstrations, including your ACO shared savings, that you're going to have to evaluate how not to impact those other initiatives. Because remember, they also have, in the ACO case, they also receive data, and they have shared savings. And one of the concerns that CMMI will have is whether what they're doing with the multi-payer demonstration will have any negative or other impact on the other demonstrations, because they're trying to isolate those demonstrations to evaluate them and their ability. So those are just some things to think about. I think you're on the right track, and I don't see any significant problem once you get your demonstration modified. I think the data will follow. The only other thing I'll give you a little insight, the person who has to put the files together reported to me, and I would always commiserate with him because his workload was higher than what he could handle. But the files themselves, once they organize the structure for how to produce the data for you, is relatively easy. It's that first go-round that takes the time. So once you start getting the data,
it will be relatively easy to maintain that for CMS. So I just wanted to let you know that. And the only other thing I will say, I don't believe you need another data use agreement or even a data use modification if this is added to the demonstration. The only time you would need a data use, an additional data use agreement or a modification to your existing data use agreement would be if this is not added to the demonstration and this is an additional use not incorporated within the current demonstration. So those are just some points I would put on the table.
Well, thank you very much, Tony. I appreciate that and appreciate you listening in and joining in. Thanks to the group for being so patient with us, because we've been talking to you and now it's your turn to talk to us and advise us. You've heard a lot of good ideas and recommendations. I welcome now your reactions, suggestions. We're going to want to come to some closure on this. Let me start with Tori.
Good morning. Thank you for your presentations and remarks. Just a point of clarification. Is the suggestion that the demonstration has to be amended or changed to the point where it would need this level of specificity in order to get the data? I'm not sure if that's what I was just hearing from our colleagues on the phone. So my sense was the demonstration was written with enough specificity around improving care, quality, reducing costs, and that is it not implied that care coordination would be an essential component of that? So the data use language isn't sufficient, that we would have to have this entire plan before we could ask for data, or is it just a higher level of comfort CMS would then have? I'm just curious in terms of that. It seemed to me that.
Okay. Maybe.
Well,
thank you.
Let me take a quick crack at it, but then Tony or Donna can correct or add to it. My understanding is that we would not have to change the demonstration, and that care coordination, which is what we're embarked on here, is viewed as a HIPAA-compliant activity under this demonstration. There are various things you have to do to ensure privacy protection, but that would be done. So that what I take away from my colleagues is that it would not require a whole new exercise or a new data use agreement, that it would be sort of, as the lawyers say, I think, encompassed by reference as part of what we're already doing. But if anybody has a different view on that, if I haven't stated that correctly, please jump in. Amy.
Just, again, from our experience, and Amy might have some other comments about this, is that if you're going to use it at the HSCRC level, that's one thing. If we're going to distribute it so the entities can use, there are very strict requirements in the secure environment in terms of where this data can be used, how it's used, who can have access to these secure environments. So I hear what you're saying, that there's possibly only one data use agreement, but it gets a little hairy if you're talking about having 40 hospitals in Maryland have their own data for their own patients, and how that works. So I'm not the expert in this, but just from our experience in this, just once we even get the files are unraveled. You're able to get encounter-level detail that can be matched to things that you can link in your own organizations to really understand what your successes are in care coordination. That I suspect that it's not going to be just one data use agreement.
And I wonder, could I ask Donna to comment maybe on two questions, because I think we may be confusing two things. One is, do we need to modify the existing contract with CMS, which is our waiver contract? Because I think I heard that on the phone. And the second is a separate question about data use agreements. But Donna, will you share?
We had very significant conversations around this aspect, and and obviously our model was around incorporating community-based physicians into the effort. That was a big part of the approach that was part of the model. So we may have to, I think we should go talk to the folks at CMS now, but the first thing we have to do is be able to tell them what we want to do. It's impossible for me to have a serious conversation with them without having exactly what we want to do, exactly how we're going to protect the patient's privacy, exactly how we're going to get the patient's consent, exactly how we're going to approach the effort. If we have to have a contract modification, I know that you all are thinking, oh my God, this is awful. It's not necessarily, it actually might be fairly easy to have a contract modification for something like this. Even as we finished the contract, CMS talked to us about, as we finish our computer programming, we might actually add some addenda to the contract to slightly change the contract. So I don't view this as necessarily as opening up the contract and starting from ground zero. Getting the contract modification, if we need one, might be the simplest thing we have to do. The hardest thing we have to do is really get our approach outlined of what we're going to do with it, how we're going to do it, and making sure that we protect the patient every step along the way and get what we want to make it happen. So I don't know if, Tony, if you would weigh in on that, that my view that the contract isn't the hard part. It's really getting our plan in place to get this in motion that is the hard part, the hard work that we're trying to do together as a team here.
That's correct. So that we're clear, I don't believe you need another data use agreement or even a modification to the data use agreement. That's a different process that you already have approval to use data, and I believe you'll be getting all the files that you need. All you need is to clarify that this particular aspect, which may not have been articulated fully initially when you did your demonstration proposal, is going to be part of your effort to control costs, et cetera. And I don't think that will be a problem. I think CMS will support that. Once there's an agreement, amendment, whatever, to your that articulates this, you're protected. And I think you want that because if some patient or beneficiary were to be concerned that their data was shared without their knowledge, et cetera, you would now have the protection to say we've been authorized by this agreement, this demonstration to use the data in this way. The final thing I'll say is this is a CMI demonstration, and I know when I was at CMS, we were very particular about what were the methods you were using to actually cause the result. And if it's not clear that coordination of care and care management is part of the process, it won't be necessarily part of the evaluation. So that would hurt you later in terms of policy development because it would not have been in the scope of your demonstration. So I think it's important to have it in there.
Okay, thanks. Lori and then Fozzie.
I'm coming back again to the whole health home concept, and I'm wondering if that is something that CMS would smile upon since they already operate one for Medicaid. It's something they're familiar with. We have patient-centered medical homes here. We have a chronic care health home here. And the people you're identifying as the people you want to target are folks with at least 2 or more chronic conditions, which is what gets you into the Medicaid health home, or one serious mental illness. It can give you the ticket in as well. And I guess I'm coming at it because care coordination, we're looking at it probably from a couple different perspectives here. From the hospital perspective, it means one thing. From the community perspective, it's a very different thing. And I think what the health home model allows is both perspectives to be blended because in our experience, if we don't work with the hospitals, if we don't work with the discharge planners, if we don't work with the primary care physicians, it's going to fail. And so the whole care planning, all of that fits into that model. And so I don't know, I don't deal with CMS, and I don't know how they would consider something like that or if that's what you all think would meet the need. But I think it's a known quantity and something that we could potentially sell and utilize.
I think if we were actually filing a brand new model like a health home, that would be 9 months to a year to get that approved. So we have no chance of doing that in a reasonable time. And I don't really think we need to. We have these new care management fees that are available to the physicians. those fee levels are the same ones that they put into their chronic health home model, the $40 a month for chronic patients. So I think we've already got the finance piece of it on the doctor's side nailed if we can get the model launched. So I think it's really more of us getting in gear to figure out how we're going to get it off the ground and get it launched and make it work with the chronic care provider. So that's really getting a formal model at this point would be really time consuming.
Just one comment, if I could, in response. I like the thought of the new Medicare care management reimbursement, but there are a couple things that come to mind. One is that the copays are still in effect for that. So anybody who's going to take advantage of that is going to be paying out of pocket to do so. And that's an issue for people who have chronic illness. The people we deal with, once you mention copay, they walk out the door. So I think, and I don't know what the paper that was sent out didn't explain necessarily whether duals would be eligible for that payment as well, because what you're talking about now, the dual eligibles, over 65% of new duals have a behavioral health condition. These are people who have real big issues.
Well, the duals have no copay. Most Medicare beneficiaries are covered by we can bring that information back in, and every service has a copay, so it's not a new problem. And the hospitals, a lot of the patients are covered. Those who have Medicaid coverage are covered. Those who have insurance as a secondary insurance are covered. And it's honestly, every penny counts for a person who doesn't have money. But honestly, we're talking about less than $100 a year, and to have access to care coordination from a physician's office. Many people are trying to, not poor people, but many people are focused on trying to get access to a regular source of care. And $100 really isn't astounding amount of money to have to put out of pocket to get care coordination, to get your questions answered by phone, and to get support. So that's where I'm going to come from. So anyway,
I agree with everything you just said. My only point is that my members have had a lot of experience dealing with insurance companies and with senior citizens. So with regards to insurance companies, they don't pay for stuff. They deny payment. They say you need prior auth. They do all this stuff. And the idea that the secondary insurers are just going to cover this fee instantly without any problems is not necessarily realistic to me based on my prior experiences. Now, maybe the insurers are going to say, this is wonderful, it's great, I'd love to pay more money out. But we should deal with that issue now. Secondly, senior citizens, and at least my physicians, though, will tell you that they do worry about the $8 a month, and that $100 to a senior citizen is a big deal. So if most people have secondary insurance and the insurance is going to pay for it, we need to educate my members that, look, this is a business model that does make sense and it works, so they do it. Because their instant reaction, and I think you saw it last night when we were at Montgomery County Medical Society together, is, oh, we're not going to do this. Everybody's going to yell at me. They don't want to pay $8 a month on top of what they're paying already, so my nurse calls them and tells them to take their drugs. So we need to make sure that we, deal with those issues ahead of time, because it is deterrent to them changing their behavior.
Okay, here's what I'm going to do. I've got 3 names, and then I'm going into my fire drill. Because you probably don't know this, but the Burlington Coat Factory, this is a Burlington Coat Factory building, and they moved out here long ago, but the bouncer is still around, and he'll take me out behind the building and kind of work me over if I don't come to conclusion on this, and you wouldn't want that to happen. So the 3 names I have are in order: Fozzie, I thought Amy had her hand up, and Ben. And then I'm going to try to get you to comment, and Deb will be involved in this, on Deb's specific 5 recommendations, modifications, agreements, and so on, so that the bouncer doesn't work me over. Fozzie.
So I'm actually going to take us back to the data questions. And I'm going to be a little bit concrete for a minute because I think we have talked about this, but we haven't actually really divided the data into useful segments where that will help us drive what things we're going to ask for. And I think you talked about this too. So I think there is a component of data that's needed immediately. It needs to be timely and not within 24 hours, but available immediately so it's actionable. Because for us, you know, with many of us, we have lots of data available to us. We have lots of available data on Medicare members. But we don't have that data available the minute they hit an emergency room. We don't have that data available the minute they hit outside of our organization. And so when we get that data 24 hours later, we can't do anything with it because a lot of decisions have been made from that initial touch point. So I think part of it is, as we're thinking about what data we're going to ask for, there has to be that immediate component of what things do we need as soon as the patient shows up wherever they are so we can help with coordinating that care. And then there's the second piece of data component, which is more for trending and quality and outcome. And when you take the larger component of data, then you know what resources do we currently have in the state of Maryland, what resources don't we? So you talk about transportation, financial resources. And so I think if we bucket them into those two groups, it'll help us be more concrete in the way we request that data and show what we're going to do with it.
And I can see us doing that. I can see us doing that once we determine what it is we're going to do. When we say we are going to provide, are you a, I'm sorry, I don't know, are you a hospital person? Okay. So when we say this is what we're going to do with the data, what of it do we need in the moment?
Exactly.
And what of it do we need, can we use for other purposes that we don't need in the moment? So, I mean, I totally agree with that. But you have to figure out what you're going to do first and then determine that.
Okay, Amy.
Great, thanks. And building off of that in terms of the data request itself, and where I heard a lot of exciting expertise from the health home model and what data you already have, I just wanted to share, building on the Medicaid health home in New York, the Medicaid data is used in mind in a very actionable way, usable real time, shows a longitudinal view in this data set of anyone who's ever had any sort of behavioral health claim or any sort of behavioral health medication filled for them. You can see every hospitalization, how long it was, which hospitalization it was. You can see every outpatient visit, you can hover over it, which doctor it was, so you can see, do they go to 2 doctors or do they go to 10? Are they doctor shopping, et cetera? You can see when the last prescriptions were filled and which exact medications. So to the point around how difficult it is to mine claims data, it is difficult, and I think that, but I do think that between the ACOs, the CMMI, and the health home experience here in the room, and maybe this one other, I think, very compelling example from New York Medicaid, I think starting to put down the exact specifications, the timeliness priority of using data, and what the use agreement might look like. So that's a place I wanted to put on the table to look for that specificity and purpose.
Okay, thank you, Amy. I have Ben, who will be followed by Carmela and Joanne, and then I will start my Sherman's March to the Sea. Ben.
I had a very small point, and this is more for Mr. Rogers, and that is that we found in some of our data collection activities, especially as we're focusing on how to make crisp information available for care coordination, that opt-out issues can be pretty daunting, or exactly what patients' rights are. Would you say that in this and I too agree that a modification of whatever we're talking about here, rather than starting over of any agreements, is a way that hopefully it would work. But would those decisions have to be specified in this modified agreement, which would mean, I think, getting together a second work group to really figure out how consumers felt about this going forward? Or could that be after the agreement had been finalized that opt-out provisions for Medicare beneficiaries be developed if they so chose? If you could comment, that'd probably be helpful for me.
Okay, so we will do that, sir. Tony, did you have a thought?
Yeah, just real quick. I do believe that CMS or CMMI will have a discussion about how a beneficiary might opt out of the demonstration or opt out of the data provisions of the demonstration. They do that with the ACOs, and they've done that with other demonstrations. And so having a point of view on that would be very important.
So would you think that trying to mirror the rules, say, of an existing demonstration, such as what's required of ACOs, would speed up the process, or would not make a difference in the case of the multi-payer model?
Well, I think there's also very specific requirements for the new fees for the care management. So I think we could look at the care management requirements. We could look at the ACO requirements and use those to drive our approach.
Okay, I have Carmela, Joanne, and Ben, and then we'll have a discussion. But instead of taking more hands, I will then jump in and say, this is what I want you to agree, modify, and so that we can come to a conclusion.
So I may start that march towards the C.
March.
As I look at the 5 items up there, my comments are in the first 2 blocks. Based on what I've heard, I think that we should make a run to try to access this data. In the first piece there, I'm wondering, are we going further than we have to? That is, it says develop detailed plans for care coordination of high-risk patients. And I'm wondering if we really have to have the detailed plan, or simply expressing the need that to be successful under our waiver, we need to have access to this kind of data. And I'm struck in this slide, we talked about a risk stratification process and a care plan for patients. And but there's another approach here, and that would be risk stratification processes and care plans, that we're trying to get access to a core of data to allow folks to do with it what they may need to in any set of institutions, organizations, ACO models, and all the rest. So wondering if we can back that up there strategically. My gut tells me resist amending the contract at all costs, and that'll be something for a discussion. But taking a look at everything that's already in there, I'm hard pressed to understand why we'd have to amend the contract, and I think that might take us down a wrong path. And then my second comment is on the second piece there, where I would just suggest we go ahead now and put together a group to help us do that work. It may be some of the folks around this table. I'll admit to being handicapped and probably unable to help, as are others, getting very, very specific about exactly what we need and for what purposes. But we've got some very smart folks here in the state. If we could put together that group, I don't see any harm in beginning to move this process down the road and see where we can get for what it's worth.
Okay, thank you. That's helpful. I have Joanne and Ben, and then I'm going to start to solicit specific comments on those 5. Joanne.
I would just encourage folks to pause to think a minute about what we already have access to and the degree to which the individual identifiers give you additional gains. As I understand it, and tell me if I'm wrong, because I may well be, we already have access to a way to link the files across the multiple files to get an aggregate CMS claims file that is specific for each person. You don't know it's Mary Smith, but all of Mary Smith's records are linked. And we have the zip code. So with that much, you can get most, for system management, if you're thinking about the Western Maryland 3 counties, you can get utilization in each kind of provider. You can get cross-setting provision of services for certain kinds of categories. You can create categories by diagnosis. You can create categories by utilization. You have age and gender. You're able to hotspot by zip code, not by specific address, but by zip code. You're able to do certain kinds of quality analyses. You can track hospital-acquired conditions. You can track pressure ulcers. You can track rapid return to the hospital, a number of things. And so we have a number of things. If I'm right on what we have in the data set, we have a number of things already. If we have enough of an identifier to also pull in MDS and OASIS, which I think Amy was talking about, then you actually have a really rich clinical data set. The big impediment is that by the time CMS mills it and gets it to you, at the present time it's about 8 months late. So what was done in January you learn about in September at best. I mean, if you have a really hotshot internal analytic team that isn't taking much time to churn things. So it is never useful for the patient in front of you. It is only useful for system management, which is true. I mean, that's a good thing. But the individual identifier does not help you with the time lag. The time lag is still there. So what Mary Smith did in January is of uncertain relevance now in September. So the gain you get by going for the individual identifiers may well turn out to be important, and it might be important to be doing in the background. But it might be at least as important to be getting the system up and running that gives you useful data with what we now have. And I just wanted to put on the table that there's a lot, as I understand it, that is sort of sitting there, not yet getting out to Western Maryland or to Frederick or to Baltimore City in a way that would allow you to see over time, because what you really want are the time series. You really want to know whether your 30-day readmissions are getting higher or lower. You want to know whether your utilization of SNFs is getting higher or lower. So it's system management things that that you can get from the claims and that you most need. So it's just as you think about the priorities, to keep the really critical time lag issue closely in mind, because it really guts it being clinically relevant. And almost all health systems, even if it's kind of patchy, have some better way of getting clinically relevant data in a timely way. So if you have even just ER utilization diagnoses, hospitalizations, transfers, and discharges on a weekly basis or even a daily basis, that's likely to be clinically relevant. The kind of thing that the Medicaid folks have put together in New York State is terrific, but that is a state-run endeavor internal to the Medicaid program. Doesn't touch anybody who's not Medicaid. And you can't make CMS run their data that way. It's not right now available. So just to kind of keep those constraints in mind as we make decisions about the priorities.
CMS has been speeding up the data. Our data lag right now is about 3 months to get complete data. So, but we're getting data every month. We're getting data monthly now. So,
the previous month?
Yes. So we get as soon as the claims processed, we get the data. So we're really not as far behind as we used to be. CMS is speeding up. But let me just say, because Joanne's telling you that we have this data. We got it as a Christmas present. We did not have the data until then. We have not aggregated the data, et cetera, and so forth. So but we just got the data.
Okay, I'm going to turn to you in a second for your comment. But let me just say, the last 15 minutes.
Right.
I'm going to give you the floor in a second. What I want to do in the next 15 minutes, because I'm a clock manager, is to be looking at Deb's 5, first of all, her overall recommendation. That's the most important thing, right? We've left it on the board, develop a detailed plan, and get you to say, I'm comfortable with it, I'm a little uncomfortable. What do you mean by this? Because I want to get you to sign off, but if you have some modifications or nervousness about something, to say it. Okay, I'm sorry. Thank you. Go ahead.
Related to Joanne's point on the timeliness of the data, and Carmela maybe focusing on the first 2 recommendations up there. Because the question I had was, in a best case scenario, because of what we heard about the detail that's required in hiring a vendor and all that's coming together,
in your expert opinion, what is the best case where we could have a time when we could have an impactful program that will help our situation with our current demonstration? Or is this such a Herculean effort that we're undertaking with all of those items up there that by the time we get it right, we're almost done with the demonstration and we don't have time to make a difference? Because I keep going back to your point about what do we have today, the low-hanging fruit, the opportunity we have with the community physicians to get care coordination going now that we have fees that already implemented January 1. And I'm kind of not comfortable to your question with this because I know we've also worked with CMS data. There's so much that can change when we talk about attribution models and getting it to be actionable at the provider level. I think it is maybe heavier lifting than we're acknowledging here. So,
and I want to comment on that because I think our initial use should be focused on using the data that we've linked across system with CRISP, and to use that to pick and target and to the best that we can do with the CRISP data. I think it's very good data. It can get us to the 25,000 mark of people that we need to focus on initially. And we may be able to help attribute that to physicians by using the process that CRISP already has, which is to have physicians send in their certified patient list, and they can be linked for messaging, but they could potentially be linked for this new process to say, oh, here's the 40,000 patients that are 25,000 patients that we want to put under our care management program, and here are their physicians, because we're getting patient lists in. So we can start with something that we can make actionable early. But if we want to get the deeper data that will help drive us into the next level of who might be high risk in the future and really trying to drive down to that next level, we need to start now in order to be able to have it. And I would say the earliest, if I said what would be the earliest point that we could actually make this data happen and start using it, is the very earliest would be maybe 6 to 8 months from now. So
I thought about a year was my guess.
and then that would be the earliest. If we were able to, it might be longer just because it will probably take longer for you all to select a vendor than I might hope for. But there's a lot, as you say, Debbie, there's a lot we can do now, and there's a lot that could even be done with the data that we've gotten if we hire a vendor to, or extend the contract we already have to start analyzing that data in the way people want it and the way Joanne's talking about, to add to our knowledge base. And then go down the road of getting this other data so that we can really accelerate the effort. So that's really kind of the thought process, if that makes any sense.
Okay. Yeah, thank you. So this is what I want to do. Thank you, Debbie. In the spirit of Debbie's question, what I want to do in the next few minutes, any of you, are there, because I take from Debbie's question kind of, don't wait to do anything until you can do everything. Sequence it. Great. Joanne was helpful. Are there other specific comments, like, gee, I'm a little nervous about this, or as you go about implementing recommendation number 2, don't forget about this? That's what I'm looking for now. Tori. Oh, I'm sorry. Scott and then Tori.
So two thoughts. One, just in terms of looking at the recommendation, I'm a little concerned that there's sort of an overemphasis on data, and that all we're working on is getting this, particularly claims data from CMS, which tends to be not very actionable because it comes in months later. But I mean, it is in certain ways. But and as opposed to focusing on sort of the first part, which is having this plan and how are we going to support the activities that are already, we have a patient, we know they're high risk. Our experiences tend to be we know who the high risk patients are. The problem is what do we do with them? Not so much being told who they are. That was the one concern. the other one is in the particular issue of attributing patients. I think we have to think through what percentage, and this will be part of the process, I'm sure, but think through what percentage of the patients that are going to be attributed are already going to be, with somebody who's taking care of them already. So so we haven't really helped them. What percentage of the patients are going to be attributed to someone who doesn't have the skills or interest in care managing them, and so that won't be very useful either. And then, what percentage are we going to attribute to someone who is interested in doing care management and with some reasonable effort could begin to care manage them, and those are the ones where you're helping making a change. So I don't know what those percentages are, but as we know, a lot of people are in ACOs already. They were already, people are all over that. They have the data already. It's not going to change behaviors in that way. So I just need to.
Okay, a very useful point. Deb, did you want to jump in? Then I'll go to Tori.
No, the only thing I wanted to make sure, because I went through this very quickly, and to those 5 high-level recommendations, there were sub-recommendations that I think accounted for some of the concerns that you have. And so I just wanted to make sure that we don't lose sight of that, because I did go through it very quickly. That was it.
Oh, okay, Tori, thank you. And then Lori, and then Amy.
So I think I appreciate Joanne's remarks. I think some of what you're talking about is kind of a little bit more population health or hotspotting versus, how do you zone in on the individuals who are in that top red part of the pyramid. In our experience with our ACO, and some of it was same as what's been said, the cumbersome difficulty in working with the data, the delayed data, and if we believe that death is part of life, we're finding that some 15-20% of the patients had passed by the time we got the data if you're really trying to hone in. So I understand we're getting a whole data file for all the Medicare beneficiaries. The whole pyramid is our goal. But I think some of our efforts, we have to be careful how much energy and resources you're putting into each tier of the pyramid. One comment. The other question, and maybe this agrees a bit with what Scott was saying, when we talk about attribution, then comes accountability. So if it's attributed to a doctor, a hospital, a system, a medical home, whatever the case may be, I think I would just put a caution on attribution, not necessarily being exclusive to a single provider. It's a little bit easier to do perhaps in my market or in Western Maryland. I'm not sure exactly how you do that around the DC Beltway or up in Baltimore. So maybe just a little bit of clarification or giving us some flexibility around what do we mean by the attribution. And then, Carmela, your earlier points on the first two, I agree, maybe not be as lock ourselves into the specificity of the plan, the care coordination efforts, give ourselves a little bit of flexibility, because I think there's the plan, what we know today, what we want to do, and then there's what we may gain insight from the data would inform what we'd want to do. So it's a little bit more iterative versus this is our exact plan, now give us the data, and this is exactly how we'll use it. I think sometimes the data can reveal some things to you. It certainly did in our ACO work, and for us in cutting that data, it was ESRD, dually eligibles, aged duals, and disabled. Those 4 categories are driving an enormous amount of your expense. And then the second cut was marry up the whole data set with ED visits and admissions and readmissions, and that became the population to concentrate on. Once you realize some of those patients have already passed, then you can concentrate your efforts on the next group at an individual level. But I would echo maybe not having such specificity in our plan, because I think the data will help inform it. But I think otherwise the recommendations are strong. I'd like a little clarification around attribution.
Okay, well, on that one point, though, and we need to have plans that are detailed enough for CMS to give us the data. So I think,
Can you explain why that is, though? Because I don't understand yet what.
Yeah.
Right.
They want to know what you're doing with it. And I don't think that we can describe definitively for you today exactly how detailed they will be. But getting them to give us data, because we're going to do care coordination, attribution, and stratification, is not enough. That's not enough. So it will have to be detailed enough to convince them that we know what we're doing with it. Otherwise, they won't give it to us. So the detail, you're kind of, you have to weigh. I mean, maybe we only go as detailed as we must, but we're going to have to work through it with CMS to figure out how detailed it has to be.
Okay, thank you. I'm going to say I have Lori and Amy, and then I think Rob, and then we're going to sort of call the question. Because I'm trying to get a list. Let me say, though, because time is a factor here, if you think of something and you say, oh, Jack didn't let me in, or you're driving back to your office, emails are accepted. Oh, don't forget about. So if you don't get a chance to get your comment in today, because we do want to come to closure, please quickly send a note saying, oh, I didn't get a chance to say this at the meeting. So, Lori.
I guess I have a question as well as a comment, and that is the conversation we're having here seems very physician-centric. So is that the design that has been submitted, and is that what we have to work with? And I ask that question because coming from a community-based organization, which I thought was going to be part of the work here and part of the design, it doesn't sound like that's what's happening. And I'm concerned because, again, the people with multiple chronic conditions, and particularly if there's behavioral health mixed in, it's not the physician where the activity happens. All this stuff about community workers and social determinants and going in the home, that happens with organizations like community behavioral health organizations that serve these individuals. I'm not trying to make light or push the physician out of the picture. They're a critical component. But what I'm hearing is it goes through the physician, and then I don't know what else happens, and I don't know how we fit into this.
Yeah, I think the attribution conversation is really about seeing who's allowed to get the data, because CMS is very particular to who's allowed to get the data, and so we're not trying to decide who's going to do the care management. Case management is not done by physicians' offices. Care coordination and navigation can be done in the physician's office. Case management cannot. And and I'm saying that there may be some physicians' practices who are so large and hire case managers that could happen, but generally that's not how case management happens. So we're not trying to drive everything into the physician office in terms of a lot of things are in community organizations, but we do have to know who we're allowed to share data with at the end of the day. And so part of the exercise is really trying to let the data tell us who we might be able to share it with because they are a caregiver of that patient. And that is really what the attribution is about, is not about assigning a case manager, but it's about deciding who we might be able to share data with in the process. So, and the regional process that we want to help drive forward is really, and when we get into the next conversation about the ambulatory situation, will clearly involve community organizations, faith-based organizations, the health departments, et cetera, and so forth, to drive the process forward.
Okay.
So I didn't mean to. We're sorry that we gave that impression, but that's
full continuum of care will be in the final report. I have to do this. I have Amy and then Rob for brief comments or modifications, and then I'm gonna. Yeah, but that's the last one. I really got to do this because I don't want to go behind the building. So just remember it. So and we do have. Pardon?
There's a junkyard dog barking out there.
Yeah, that's right. Okay, so then I'm going to call the question. It doesn't mean you can't send in notes. There's going to be a report drafted for this committee, this work group. You will be marking up drafts, and so this isn't the end. We got another month and a half here, but I do want to come to closure on this and call the question. So, Amy, Rob, and Jean, if you could be as quick as possible.
Well, okay. So I have to thank you for my colleagues for your comments about attribution and plans of care. It does not seem to me in this conversation, I am a little confused and I apologize, where the hospitals sit in all of this. We're kind of all over the place. We talk about ambulatory being the next discussion. Right now, we're focused on what's going on in acute care through the transitions back to the community and what those structures currently look like. The use of the Medicare data, in summary, can give us invaluable tools to evaluate the current activities that are going on in Maryland hospitals, which I suspect if you all did a catalog, you would be probably very surprised at the scope of work in all of these categories in terms of risk modeling, in terms of identifying your high utilizers, in terms of identifying anybody who's being hospitalized, and then all of the post-acute interventions that are occurring. I think we should prioritize what the Medicare data, what we want for it first, before we say we're going to attribute to community physicians. The first thing we need to do, since the hospitals are on the hook, is figure out how to use the data to see if the interventions we're doing are working. So if I'm scheduling post-discharge appointments on patients within 7 days, I want to know if they kept those appointments. And if they didn't, how do we identify those patients a little bit better so we can ensure that those are the ones we're calling and making sure somebody holds their hand to get to the next appointment. But this is the kind of work that is currently being done. I caution about using predictive modeling. Our organization and Johns Hopkins Healthcare, within the aspects of the grant, have used a variety of different predictive modeling. It captures 30% of your high-risk patients. The rest is done by individual assessment and putting processes in place that you are really assessing every patient who's admitted to a hospital. And that same thing is happening at the community level as well. So I just want to be cautious about that. I think the Medicare data is a rich data set to help us evaluate what we're currently doing and to help us pivot and then target other things that we need to be doing. But I think we have to be very careful about being prescriptive about detailed care plans and a variety of things, which I've never seen Medicare data be able to really give us.
Okay. Thank you. Rob, Jean, quick points then, because we do have to do justice to the nice introductory presentation that we got from Donna and Carmela. Go ahead, Rob.
Thank you. So I would say I do support this list with the comment that I agreed with what Carmela said before and what we've been talking about not going too far in terms of the description of the care plan. Since there's been a lot of discussion around what you need the data for, the Medicare data, I do think it's important on the very front end. This is a Medicare fee-for-service population. We're talking about the Medicare population. I think it would be very helpful to help us get from 800,000 people down to 40, 80, or 120 in an organized population-based fashion, and then you pivot, as Amy said. And then the care plans do start to take over. You are getting regular feeds. This is helpful. But I think of it as sort of a microcosm of the Medicare Health Support Program, where the federal government said they started by saying, here's 7 million people out of the 45 million with particular chronic diseases. Then they further drew the line and said, from these 7, we're going to target these 3 million with particular risk scores. I really think it would be helpful to use a population-based fashion to get from 800,000 down to a manageable population. And then I agree with Amy, at some point you do pivot. But I think that's also important in terms of the data request. In other words, Dr. Sabi was talking about, you're a payer, so you know sort of who your population is. So you talked about minute-to-minute care planning and then quality and feedback looping. I think of the reason we need the data is we need the very front end. Again, just narrowing down from 800,000 to the population on which we want to focus. I can stop there. The only other thing I'll say is I think this chronic care management fee has come up, and we can talk about that later, but I think that's hugely important.
Okay, Jean, last word. Then I'm going to read what I've heard, and then we're going to ask you for your support, subject to you can send in some later thoughts.
I think we have consensus around this. It's been brought up by other people in prior meetings, but the last recommendation about identifying a vendor, it seems to me that somewhere in here we should talk about CHRIS specifically. They're not in the list. And frankly, CHRIS should either be tapped to manage that process or deal with it. I mean, some of the people sitting here on their board, they got a cross-section of folks they're dealing with. They're used to dealing with issues. They're the right folks to do this. And I would feel better about it. And I think it would make other people feel better about it, given the good job they've done on other projects, if they're mentioned in this and considered. And I think we all think that, but I just wanted to make sure
I'm glad you brought that up, and David Horrocks is here. And in the next section to lead off, or whenever he wants, I'm going to ask him to jump in because I agree with you, and thank you for that. Here's what I have. Now we're going to call the questions, and then we're going to move on. I'm sorry, but I just, you know, I want to be fair to the next session. This has been a great discussion, and thank you for all. Here's some things I have. If I miss your favorite point, send me an email. What can hospitals, concentrate on what hospitals can do with the data they already have. And part of the spirit of this is you can move down parallel tracks, and this is similar with what Joanne was saying. This isn't, don't do anything until you have everything. Hospitals can identify people that are streaming back and forth through their EDs and inpatient multiple, and they have data, and let's not forget about that. And Joanne pointed out some things we can be doing with the data that has not been identified down to the individual patient's name and address. Number two, what can we do with the data that state agencies already have? That's Joanne's point. Number three, learn from the data and modify accordingly. Learn as you go, which I agree. Number four, not too much specificity on care plans. Allow yourself some flexibility. Number five, some of you said we need more clarification on attribution. What does that mean? You know, and it can mean different things. And is it going to the people, the physicians that can really do it? Are they capable? That's an alert to us. Number six, which I believe was brought up by Lori, point near and dear to my heart, full continuum of care. Hospitals are critical, physicians are critical, but in the world we live in, so are pharmacists, social workers, nutritionists, people that work on transitional housing for low-income people. Our report will reflect all that with your guidance, so point well taken. Number seven, prioritize and recognize the limits of predictive modeling. It can be helpful. Number eight, oh, I've already covered that, sorry. Just two more. Number nine, Rob's point, you can start with the top 20,000 or 40,000 and move out, and population-based health, all these things have price tags. But reminded from Donna's chart, 14%, I mean 50% of the cost. If you started with the top 1 or 2%, you could do a lot. And last point, don't forget about CRISP, which we will not. Those are the 10 points that I captured. I know there's some that you can think of and that I haven't captured, but I tried to capture your best suggestions. What I want to do now, and then we got to move on, is to say, again, looking at that recommendation, subject to these qualifications and concerns, and a couple others that may come up, are you comfortable with supporting this effort as Deborah has laid it out? Details, sure, to be worked out. Does this make, are you comfortable with this being a major recommendation of this panel?
Are you looking for a note?
I'll take one. I wasn't going to do it, but you know, but yeah, I mean that would be fine.
We are a consensus. We have a consensus approach, so it would be good to hear. You know, we can still have a show of hands, but it is a consensus approach.
Yes. Yeah. Well, let's not vote. We're not going to vote. We're not going to vote. What I'm, yeah, I hear you. And there, yes. Okay. So let me modify that. No, I don't think I want, but thank you for offering. I just want to see heads nodding, and I'm hoping that someone won't say, but if you do, now's the time. Are you comfortable, heads nodding, not a vote, with moving ahead and supporting this the way Deb is? I'm seeing a lot of heads nodding, and nobody's throwing anything at me. Steve?
I am.
Okay.
And some of this comes from, I think, nothing for exactly me, nothing. This is a big project.
Could you use your microphone, sorry, so the folks on the phone can hear?
Hi, everybody on the phone.
You're still not on, though. There you go.
Now I'm green. Wow, now I'm overhead. I think people have emphasized around the table, this is a big project. There are a number of questions along the way. The goals of the project seem a little bit diffuse. and we've started on a strong pathway of narrowing a population. I've been sitting here reflecting on our presentation about Kaiser last time, and this is an entirely different population, Medicare fee-for-service group. So we've become very Medicare targeted. And I'm not sure it matters which group we target. There's something to be gained in any group, both in terms of patient care and economically. I'm not sure the goal of this large data project. And I'm not sure, as I've been listening to everybody, I'm trying to think through the success potential of whatever goal we're choosing. I think we would all feel somewhat responsible should we pursue a large data project that after a year or two comes up not actually doing whatever it is we hope it does. If the goal is to produce something that allows a statewide, regional, or systems ability to analyze the Medicare data and track across time, that strikes me as a highly feasible goal. I've been wondering the clinical applicability in front of the individual patient with the time lag, the questionable sort of data that will come through, the onslaught of garbage data that will be involved that has nothing to do with clinical care but will still have to be sorted. And every practitioner I've heard speak around the table has raised the question of the clinical applicability of the project when you're sitting with the patient. If the goal is a systems-based approach to tracking things across time, it seems there's a reasonable chance of success. If the goal is something that is clinically applicable to the individual patient sitting in the exam room, the mental health office, or in front of someone trying to figure out their housing, I haven't heard enough to make me comfortable that there's really much of a chance of success at all. And that makes me uncomfortable.
Well, I understand your concern. I think that is one of the uses of it, is to track across time. And I want to assure you that I'm not suggesting, I don't think anybody at this table is suggesting that we're putting all our marbles on this. And Deb made clear in her presentation, and I want to underscore this, that getting Medicare data is necessary, we think, but not sufficient. And it has all the limitations that you've described and others. And there are other data that physicians need that she has pointed out, and that they need at their fingertips in real time, and hospitals at the bedside need in real time. So I want to assure you that we don't think this is easy. We don't think it solves all the problems. We view this as requiring a multifaceted, multi-intervention data, multi-intervention strategy. We do think, however, that sort of the Willie Sutton effect comes into play here. Why do you rob banks? Because that's where the money is. This is a state with 90 to 92% fee-for-service in Medicare. The national average is about 70-30, as I understand it. You've got a lot of unmanaged seniors. Some of them have 5, 6, 7, 8 chronic diseases. Others have cognitive impairments. Others are ESRD. Others have severe physical disabilities, quite a diverse. And so I think the reason we want to start with this is that it's this opportunity. You know, Medicaid is almost all managed care, I think, in this state, or heavily managed care. This is an unmanaged population, so the goal is to try to start here but not end here. So I guess I would ask you if you feel comfortable, and I'll note this as a concern, you know, that we must address this and that there are limitations of this. Do you feel comfortable supporting an effort with the caveat that it would be used for overtime tracking in joining the consensus with your reservations? Oh, yeah, let me let Mark jump in.
So I do understand your perspective, but so the hospitals under the global budgets are already on the hook here. And so we need to do case management and care coordination to the best of our individual abilities. And we believe that access to the Medicare claims data is ultimately going to be part of the requirements for success. I think the question here is whether we do that 12 to 15 different data use agreements with CMS as 12 hospitals, as 8 hospitals, as another 10 hospitals, and then potentially representing a number of others. Or are we going to do this one time? What I would suggest, and this is my challenge here, is I do understand the specificity you need, but we, the providers, also need the ability to innovate on our side. And if we are too exclusionary to that innovation, we're going to have to go out and get this data ourselves and do it anyway. And the attribution question is absolutely important. Right now, though, it has to start with the hospitals. And then we attribute to physicians, and then we attribute to the community. So starting with an attribution model, but allowing the program to explore other potential attribution models would be the way I think we'd want to set this up.
And I do want to say the specificity isn't how you're going to do attribution, but if you're going to do attribution. So that's really a lot of what we're trying to say, is that we need to say to CMS, we're going to do A, B, C, D, E, F, G, H, I, J with the data. It's not, we're going to do it exactly this way. So I think that was a good modification of the recommendation and the clarification that it's not about how we do it exactly, but what we're going to do and who we're going to share the data with. And that really gets to drive the process with CMS.
Okay, thank you. And thank you, Mark and Donna. Here's what I'm going to suggest, and I'm going to look to you to see if you're comfortable with this. I'm going to suggest that I'm hearing a consensus to move forward with some significant provisos and with some concerns, as stated by several of you, but most recently Steve, and that those should be taken seriously. This is not the last crack at this. This group is going to work on a final report, and all these can be put in. Okay. Oh, okay. Fozzie and then.
Can I just make one clarification? Because I think many of us sitting at this table feel this, and I want to say this on behalf of many of us. I think many of us are managing Medicare members very well. And I think that there are a large number of Medicare members that are managed well in the state of Maryland. But I think the clarifying point is this. I think it's getting all of us who are innovating on our own, managing these members on our own, to collaborate and work together. And I think that's just one sticky point that many of us, every time we say they're a whole group of unmanaged Medicare members in the state of Maryland, we say, no, we're managing them, but how do we reach across the aisle and manage them together? And I think that is the nuance of what we're trying to say here.
Oh, thank you. That's very helpful. That's very helpful. Debbie,
the point I wanted to make on record, I heard Donna say it numerous times, but I didn't hear it other than in her comments about the tremendous responsibility we have in getting this data. And, you know, for the citizens of Maryland who would have major concerns if this is not protected and used for clinical purposes and in the right way. And I think it could be a whole huge headache for the state of Maryland that needs to be considered, because it is, I mean, there's a reason why they go through all of those requirements in the data use agreements and lock it up like Fort Knox. I mean,
yes, literally, in the case, I mean, I'm a researcher.
Really, yes.
We had to, my database manager, every weekend, it had to go in a bank vault.
It is a tremendous responsibility, and I don't think that that should be, you know, underestimated.
Point well taken. Carmela, last point, then I'm going to try again.
Let me see if this is helpful. We've talked about data for system management purposes, for population health management purposes, and that can be done with existing data, linking existing claims data, and maybe we need to make it explicit in this recommendation, whether it's CRISP or whoever's going to do it, there is a bucket of work that we can start now, and maybe making that explicit. What we're talking about is if we want to get individually identifiable health information, we only have one window we can go through, And it's a very narrow window, and that window is called care coordination. That's the only way we in Maryland will qualify to access this deeper individual-specific data. To Steve's point, what is the clinical application given the time lag? I may be, I don't know what the right word is, I don't want to say cavalier. You said at the beginning we wouldn't want to come through this process and not be successful at the end. On the other hand, this has never been tried or tested before, and I'm not certain it's bad to try to access the data and build our capabilities, even if it turns out 2 years from now we're not successful in getting where we may want to go. So if we add the other data steps up front, focus on the care coordination piece with at least 3 cautions. Don't be too prescriptive. Don't open the contract. And we've got to work through these privacy issues before, and have that all those ducks in a row before we make the ask, is what I'm hearing. Yes. I don't know if that creates more of a middle ground.
Well, thank you. That's what I'm trying to do. And so, and I don't want people to think that I'm forcing unanimity here. I'm trying to get a consensus subject to concerns. So I will ask again, subject to all the important caveats, concerns, and Fozzie, what you said was so helpful, that this doesn't, people are managing care, but they're doing it each on their own and reinventing the wheel, and nobody's kind of linking up. Subject to all these legitimate concerns, are you comfortable with moving ahead, recommending moving ahead? And again, you'll have a chance to review specific language and draft chapters.
And moving ahead may mean continuing to flesh this out.
Yes. Yes, there may be a point where somebody pulls the ripcord down the road. Or goes to CMS and they, we don't know. It's just moving ahead. This isn't a commitment to go every step of the way down the line, but to move this initiative. Are people comfortable with that?
Can I just make a suggestion that, at least to start, and there may be phases on what we want to do here, is that we go ahead looking for the data set to help us analyze where we are, what we're doing, and where to focus. You move from that to what other applications might be for the data set. There's
yes.
a clear use for this data set now in evaluation, even as we're at the beginning, and some of us not so much at the beginning. There's a use for the data now, but it will evolve as we understand it more. So maybe we don't say it's everything, but that we have basically a gauge or a continuum on how
yes.
we're going to use it.
And you recalibrate as you go. Absolutely. People come. Yeah, yeah. I'm asking for another date. Yeah, a couple more dates. Everybody cool with that?
Okay. No, I'm not cool with that. We either have to get individually identifiable data or not. It's not one. It's one way or the other. So we have to say, hey, we don't need it, or hey, we're going to go after it, and we're going to do all the things that we have to do. So we already have the other data. We can figure out how to hire vendors to get what you want out of the non-identifiable data. But if you want identifiable data to use for population health and stratification and et cetera and so forth, then we need to say, yes, we're going to go march down that road. And you could stop marching down the road, but we have to say
right.
yes.
So I'm hearing, yes, start marching down that road. Okay? Good. Thank you. Closure. Now, what I'm going to do, you can come back later. But, I needed to do that. So now here's what I want to do, since Amy deferred her discussion, and I do want to bring in David if he has a chance. We're going back now, and if Matt, if you could get us back to the slide, I think it was 13 in Donna's presentation with Carmela, the blank slate chart. Take your time. We'll try to fill that in the time we have. Amy. Mine. Oh, I'm sorry. Yeah. Sorry, Matt, I gave you the wrong signal. Amy, slides.
Yeah, I'll be very brief because I want to acknowledge and recognize that many people have already said, let's use the data we have and let's move forward. And there is already management going on. There's already efforts going on. And one thing I just wanted to share in that vein was a spirit of inspiration and potential on collaboration where you were trying to get us to go based on the information that we're already doing, managing the patients we already have. And sorry, it's called Boutwell, so it should be at the top. Oh, is it on my jump drive? No. That's okay. So I'll just, in Massachusetts right now, over the past 12 weeks, I've been fortunate to be part of a very exciting public sector undertaking from the Mass Health Policy Commission, which is stimulating 28 of the 50 hospitals in Massachusetts, so a super majority of community hospitals, non-teaching, nonprofit hospitals, to take that leap forward, to identify the patients they can identify right now today based on their imperfect data, and then to recognize that data is imperfect and to get together and to start actually coordinating amongst each other on who do we share, what community services are they using, and how do we actually take that next step forward. And what I had wanted to share with you were just a couple of visual slides on this, this very quick 12-week process. Thank you. I call it 12 weeks, 28 hospitals, and 100. Go back. I just want to point out 172,000 targeted opportunities. I think that's really where Donna and everyone wants to go. With what are those targeted opportunities? And what we've done in 12 weeks, as of yesterday, and this is fast-moving train, is identified 172,000 targeted opportunities among the shared patient population of these 28 hospitals. And we're going to be launching on March 1st, coordinating, deploying, collaborating with community partners, et cetera. Next slide. We've walked through this 10-step for granted as a throwaway or give me like that's obvious, but these hospitals, I will share, had never, they had heard of the STAR initiative, it's my home state, they had never done these interviews, or they hadn't done them since about 2009, and so they said 100% of them said actually talking to patients really changed our focus radically. We get what you're talking about in terms of behavioral health and social complexity now. We finally get it. We asked them not only to identify high utilizers, but how many people is that? How many discharges is that? How many emergency room visits is that? And all of a sudden you start to paint this picture that there are a couple hundred people using several thousand ED visits and discharges. And when providers say, well, a couple hundred people doesn't seem that high leverage, you pivot over to the unit of discharges and utilization, and it's dozens of people a day, as it turns out, at their hospital. Next slide. So just to paint a picture on the data that hospitals can use and can have, and that we actually ran with all these 28 hospitals. This was a readmission analysis, quick, dirty, doesn't have to be sophisticated, not risk adjusted. This is just real numbers, Medicare, Medicaid, commercial, and all. Next slide. This was the ED analysis that we did. Again, it doesn't matter what the details are, just to say we looked at revisits, we looked at behavioral health ED, we looked at high utilizers of the ED in the inpatient setting, and just decided to use the information the best that it could tell us signals right now. Next slide. Of course, they had guidance on getting out to the patients, because that is hard if the teams are not used to doing this. And we have some great leaders here around the table. I do not doubt that your systems are doing this work, but it may not be the case that every hospital in Maryland is doing this work quite yet. And it has turned out in Massachusetts, again, a prime and ready market that knows a lot of this. The hospitals are very well educated about these utilization opportunities. This was still new work and new insights that, as of yesterday, were turning out to be very valuable. Next slide. This is some of the key things that had not been done was who is your target population? Not chronic illness, not top of the pyramid, if you will, but literally how would we pull them out from our data and how would we run a list? This is getting to Mary Jones, going from population health to who's the list of people. and what is the aim? It's not to reduce readmissions by 20%, but next slide. It's saying, here's our overall hospital ED or readmission rate. Here's our target population rate on the lower half of that slide. And the cool thing is that, again, just with this cohort I had worked with, but I feel like they're probably representative of at least a component of the market here. They hadn't done the work of saying our hospital-wide all-payer readmission rate might be 8%, but our target population defined as X, Y, and Z that we pulled from our own data, now we can see they have a readmission rate of 30%. And we know how many discharges per month that is and how many individuals. And then this last exercise here on the table was 20% is hard when you're running a multifaceted program. Converting discharges per month less 20% equals 18 or 32 fewer events per month, so that you know if you only reduced 20 readmissions in March and your goal was 30, you got to do that much better in April and May. And this is really bringing it home to how are we actually going to leap forward from all the stuff we kind of thought we knew into something very concrete. A couple more slides. So the neat thing is, again, 28 hospitals. So I have 2 slides going through A through W of these community hospitals, using their own data, going through this analytics, using their own decision-making process. We did not tell them who to focus on. We supported their analysis. We answered their questions on how to run their data because, again, they hadn't done this before. We supported their interpretation of the data. And amazingly enough, and this is, again, just hot off the press, we've come up with a accidental consensus that high utilizers, frequent users of the ED who have behavioral health comorbidities, patients who are socially complex, dual eligibles, and all manner of patients being discharged to post-acute care settings and patients at end of life, we did not tell the group that that's where they should focus. We did not come out with a programmatic mandate to say, we know what the high leverage opportunities are. Every one of the 28 hospitals these are their self-identified target populations and quantified number of ED visits and discharges per year they will now focus on. And I think it respected back to Carmela and Donna's table about what can be done at the state level and at the regional level and at the local level. I think this is a really exciting recent example in my experience of coaching through and providing some semi-structure or unified mandate, which of course the GBR program waiver does anyway, respecting individual local interpretation, but then, next slide, aggregating it up to the regional and state level to actually just drive that train and keep progress moving, because this has been a whirlwind in Massachusetts. Again, we started this since your last meeting in December. It's just incredibly intense. A couple quotes from the field. I won't read them out loud, but you can see that hospitals who know these issues, who have been working on readmissions, who are getting slammed with penalties in my market, nonetheless said that this new day, this new breadth of semi-coordinated planning was really helpful. Next slide. And so, of course, what we're doing is now, just yesterday, we met with the West Central hospitals, 11 hospitals. The room was full. We literally started having the conversation. You have your high utilizer list, and you have your high utilizer list. How are we going to look at this list together? And that is where the February 2015 work will start. We know we have high utilizers. We know we share them. And now how are we going to actually get our compliance officers, get our policies and its care coordination ducks in a line to really say, yeah, we're going to sit down and run lists and coordinate care. And that conversation started yesterday, and I would be really excited to see those conversations start in Maryland. A couple months from now. Doesn't need to wait. Again, with what everybody was talking about parallel processing, best available data, with getting scrappy and started and building. I shouldn't say started, because it's really building on everything that everyone's been doing individually and learning individually to really kind of come forth with a new, updated, and coordinated sense of urgency to get going. So thank you for the time.
Thank you, Amy. That's like the halftime talk by the coach to fire up his team to go out for the second half and do her team to do better in the. Thank you. That certainly illustrates the point we've been making, that there's a lot that can be done with what you have, and that's a compelling example. I want to give a chance to David, if you would like to. Chris has come up several times to just say a few words to orient the rest of our discussion, because we're going to be talking about what can be done at CRISP, but other ways, and then we'll start to, in the time we have, fill in the chart a little bit. David, somebody give David a mic, please.
Thanks, Jack.
So just pull up a chair.
Right
yeah, join the group.
I'm Neil right here.
Kneeling is fine.
First, I just want you to know that you can count on us to step in and play whatever role it is that is the consensus of the group on the Medicare data. We talked about it at our last board meeting, and this is very consistent with what we're doing with existing data. And I like to think that certain of the structures that we have, our relationship with HSCRC on that existing data, and a reporting analytics and committee, which is comprised of, largely comprised of your colleagues, to help guide and prioritize that. And I think those infrastructures will be helpful to the extent we need to do RFPs for a vendor and those sorts of things. So I want you first to know that you can count on us for that. When Joanne said, we have a lot of data, and I think everything you said is true, although we don't have so much of the MDS or OASIS. But we have even more in that we have it identified. And we're going through the same challenges with that identified data. Some of it's clinical data that we receive directly, some of it's case mix data, which I think is largely all the Part A data. But we're going through some of those same challenges of patient consent and the provider relationship identification or attribution, if you will. So we're going to have to go through those issues either way, whether it's with the Medicare data or with the data that's already in existence. We're creating these draft reports and all. What we are really eager for, honestly, is that first box on the presentation to get some direction from you as you come to consensus. And whether that's for regional things or individual or statewide, we just need some direction so we know how to target our efforts. And so I look forward to your efforts. I don't know, Mark, if you want to add anything.
So what David said is that we did have an executive committee meeting of the board last week and did discuss the ongoing work of this group and how we, the board, want to make sure that we keep CRISP aligned with where the HSCRC and the state is going around use of data and development of models.
Thanks, Jack.
Okay, well, thank you. To join in again, and there may be some questions. So what I'd like to do, Matt, maybe you could go one step chart ahead of that, and we'll flip back and forth to chart 15. Sorry. And I probably shouldn't ask you to do that. Yeah, if you could bring up 15, and then we'll take it back. So, yeah, 15 is a preliminary list that we all put together of possible areas of state collaboration. You will think of other ones, and some of these. So what I'd like to do now, and I know that time is tight, is to get your thoughts. Do those make sense? Are there other areas where it seems natural to be making statewide investments? What would be the repository? What's the role of CRISP? What kind of investments in tools, care plans, data, best practices, evidence-based practices, and IT issues, even workforce? What kind of investments would you recommend be done on a statewide basis. I think Donna or others made reference to the BRFA money. There are opportunities here to create public goods, as we call them, that all can share. There's certainly a goal of not having, as both Debbie and I think Fozzie pointed out, not having everybody reinvent the wheel, but collaborate on what they're already doing. Ideas, please. Thoughts. Gene, I'll start with you.
Medicare has long supported the idea of a Medicaid ACO around dual eligibles, and Dr. Herrero was very helpful in the SIM application and putting the language in there around that, which we appreciate. My understanding is that there is approximately $2+ million that came back to Medicaid to move forward with planning for that project, possibly. And my thought is that that seems to me be an opportunity for us to coordinate that activity, what we're doing there, and we should urge that move quickly and that we start doing it, because if we're going to do something around the duals, that would be smart and we could work together.
So that's already happened, and I think Tricia's been working. We're starting the discussions with HSCRC. It's $2.5 million, and we're just scoping out what that will look like and where we'll spend it. Mm-hmm. And so that's already happened. So
we should mention it, coordinate it, stick it in here, and maybe you guys could send us some one-pagers or something or whatever you have on what you've done, what you can share. I understand the.
Sure. The key thing, though, it has to be planning. The dollars can't be spent on anything that's implementation.
Right.
Point well taken, Gene. That
we should add it to our list,
of that as that's going ahead.
And it totally matches what we're talking about.
Yeah.
So we should move it quickly and work with them. And Medicaid's got a lot of pressure with other things going on, so it could be easy that it could slip to the bottom of the plate with the other issues they're dealing with.
Right. And anybody, by the way, I always do this as a facilitator, sort of like same with students in my classes. Is there anybody who hasn't had a chance to say anything that would like to speak up? Dr. Carter.
The problem I have is, and I guess, and I'm new, so I'm trying to get my arms around it, is that you say you're going to push the ambulatory piece to next week, but we've got to determine a plan for doing care coordination. That sort of is disjoint to me. I can't, so just to take the example, so hospitals, when they do care coordinate, this is the way I look at it. I'm just going to say it very clear, succinctly. When a patient goes into the hospital, they are very controlled. They have their environment controlled, their social services controlled, they have nutrition. So what happens is you can practice medicine in a hospital and get everything else controlled. So when I was doing neonatology, we have a baby come in, that baby's sick. We had a team of pharmacists doing medication therapy management. We had social services taking care of X, that everybody was happy. All the environment was great. And then the case managers came in and said, okay, we're going to do X, Y, and Z so they can, transition out. But what happens is that once they leave the hospital, all of those things that were in their environment all of a sudden becomes non-controlled. Their social services are all over the map. Their behavior completely changes because their behavior in the hospital is different. And so that little transition service that the hospital did was great up to a point. But then the patient drops all of that, and they go back to what they were doing, and they, and whatever happens, if they're going to be readmitted to the hospital, they're going to go back into the same habits. There has to be, so for care coordination, it's just very difficult for me to see it as just that. We have to, when we're looking at it in the county for our populations, and when you look at that 1%, there's different kinds of people in there. There are people in there who could do okay with that type of case management, but then there are a lot of people who are going to need care coordination that's outside of that. And then, so you say, well, you got patients in a medical home, but believe it or not, the patients in a medical home, some of them are great at it, some of them are horrible, and you have to, so from a state's perspective, you got to start thinking about how do you coordinate care for a population that once they leave the hospital and you lose that, because there's a gap, how do you get them in a situation like you had them in the hospital where you can help them with their, If not, you're going to go to this vicious cycle. You're just going to push it out. You know, say in 30 days they went to see the Dr. Gray. But nobody has any data about what happened 120 days out, because I know I looked. Yeah. So because I've been really, really focusing on it. So I'm saying that all of the services that are out there, they're a conglomerate of services. They match different populations along that risk stratum. And those that we really, like, because I'm looking at Prince George's County Hospital, those that are in that little 1% are exquisitely difficult to manage their care. I mean, and there's no way, and if we don't look at that from the state level, you're going to create a system that they're going to be down here, and they're going to be driving costs constantly, and it's going to be, and the hospital's going to be seeing them, you know. We've got to figure out how to manage everybody, and I just believe that if we don't take that approach, at least have that framework at the beginning, and then put the hospital framework here, the ambulatory framework, all of the different things, you're going to have a big gap. I mean, at the end of it, those people in that at the tip are just not going to be cared for, because that's what we're seeing. I mean, we're trying to do it. We're doing use cases. We're seeing, and I think somebody talked about it, at the point of care, you need all your information at the point of care, but you just don't need all of the medical treatment information at the point of care. You need social services information at the point of care. You need housing. You need everything. And the majority of our patients who are bouncing back into Prince George's County Hospital have behavioral health problems, huge housing problems, and I can just go down the line. So that's a very and then we get people who want to do transition services for them, but they say, oh, but we just want the ones we're going to get like this. Then the other ones are just, what happened to these other people? So from a public health perspective, and I'm just from a healthcare, the state is concerned with the public, and so we've got it. I'm through.
Oh, but I think the question is, what can we do at the state level to address? What are the things that the three things that we can do to address your needs? And you're already doing a lot of things at a regional level, so you can teach us what could be done at a regional level, as we attack the
okay. Yes, but first, if you just indulge me, Dr. Art Jones, who came all the way from Chicago, and a colleague of Deb and mine, had his hand up, and he hasn't had a chance to say anything. So, and he had a thought on Dr. Carter's point, and I want to give him a chance. If somebody could just hand him a mic. Thanks, Art.
Thanks. Let me just comment on what we've done, just to give you a historical perspective from Illinois. So the last 2 years, we've been getting real-time ADT feeds, and we've been getting weekly dumps from our Medicaid, 170,000 patients, weekly utilization data. And I think really what we did was we built a warehouse that uses that combines the historical data. And I think that's where the value of historical data is, so that when you get a real-time alert that somebody's in the ER, someone's being discharged from a hospital, what do you do with that? And that gets driven down to the care management level. And what we've also done is we have done a 5 to 7 minute HRA on all of our patients that goes at those social economic risk factors. And that goes into our stratification. Because what my care managers want, which are at the practice level, they want a real-time alert, and they want to say, okay, that patient is in the ER. Okay, what does that mean? And you deal with that very differently if that patient is someone who has never been to your practice. They want to be able to walk in the morning, have a prioritized list to say, this is my patient who was discharged yesterday for pneumonia and hasn't been to the pharmacy, because now we're working on getting real-time pharmacy data. And they want that prioritized so that when they walk in, that's my highest yield activity today. And I think that gets to what, in my mind, the historical Medicare data is a context. I think the HRA historical data you've collected is a context that you would then interpret the real-time alerts which you guys have, at least from the hospital. I don't know if you're getting pharmacy data or not, but you can get pharmacy-filled data on a 24-hour basis. And I think the role for the state is to sort of say, can we use our data analytics and our warehousing capability to push that data out to your care manager so that it actually becomes actionable and you can get an impact. We've done that for the last year. With the state, we had a matched cohort element, analyze the data. We cut 3% of the cost out. I think we ought to cut a lot more on our global cost with the fact that the state of Illinois and CMS have been so slow in giving a shared savings opportunity for the providers. So we gave them a care management fee, but there wasn't as much incentive. So now we're finally getting that incentive, because I think you have to tie it together with your physician incentives. But that's where I think the role for the state could be, is to really take this data, because you get into real-time data, interpret it, drive it into actual tasks at the practice level or the care management level to allow them, because too often care managers just work in a black box.
Thank you, Art. That's great. Steve? Yeah.
If I understood correctly, you said you were using Medicaid data, and somewhere there was a specific decision made to pursue that somewhat different population than what we've been talking about. What were the dynamics around that decision?
The dynamics were that it was 9 FQHCs and 3 safety net hospital systems and we had collaboration with the state on a demonstration with the state. So that's where our focus was. Doesn't mean we can't expand to other populations, but that's where we're able to get funding and our demonstration with.
Good. Thanks, Art. Other ideas? Amy?
Just to feed onto some of these points and the themes that we've seen, the things that lend them potentially to state activities that could be low-hanging fruit would be projects like the Interact project.
Yeah,
so Interact is a very specific, it's well-developed, it's been spread all over Massachusetts, as Amy knows. It involves the nursing homes. It is a good use of standardized practices and education of the SNFs to really get everybody into every single SNF into an Interact competency mode. That would be one potential, and it's free. I mean, we've got the tools.
You can download a toolkit.
Right,
yeah.
but what you would need would be facilitators. I mean, you need people who really understand how to cleanse specs or other types of people who go into the SNFs and who have an education ability to go in there and teach. We have a prototype of that in some of the work that we're doing right now in our partnership with the CMMI. But again, the tools are there. It's easy. It's low-hanging fruit. It's especially valuable for our particular areas that have 50% of our patients are Medicare. So that's one potential. The second thing to address the issues that have come up over and over again, our highest risk utilizers are also the most expensive to intervene on. So we have multiple tiers of activities because any patient who enters in the hospital, even if they're healthcare literate or whatever, if we do something to you, you're at high risk. And so there's the group that we can do a better job in terms of education, self-care management, post-discharge phone calls, a variety of things that are less costly. But the groups that you're talking about with the high socioeconomic and demographic risk, patients with social issues, patients with behavioral and behavioral mental health issues, those are the patients that we are throwing everything at, and we need a more coordinated approach in the community. We have very limited community behavioral health services. We are having a terrible time in Maryland with these patients after they're discharged or after they've been in the ED. The lack of community support for specific programs for behavioral health is huge. The other part of it is having community expanding services such as HCAM, Healthcare Access of Maryland, which is really in its infancy in terms of community social work, but expanding resources to that group so that all hospitals have access to that kind of community social work, again, for our highest risk individuals who need that kind of social support. Those are some of the things that could be done on a state and regional level.
Okay, thanks. Yeah, Interact is a good program, Project Red, Boost. There are quite a number of models out there, and we will be looking at long-term care transitions and working on the problem of a lot of people in long-term care facilities who keep getting sent to the hospital for conditions that could be managed back there, at least trying to. I'm now going to try to perform a quick magic trick. No card decks involved, which is to take a 15-minute segment and take it down to 40 seconds to a minute. That's next steps, because I want to allow a few minutes for some questions or comments, and I want to turn it back to the chairs. I'm sorry I cut you off a minute ago. I wanted to get Art in, but I will turn back to you and Laura in a few minutes, just a couple minutes. The magic trick is next steps. We at HMA are going to be starting to draft some chapters over the next few weeks based on what we're hearing. Every one of those will be edited and improved based on your feedback, but you can expect to start seeing some materials in the next couple of weeks, because this group is going to be, and it'll be your report. We're just going to help you by starting to put things down on paper for you to mark up. But we can't wait till the end of the meetings because your report is due on March 15th, and that, so we got to do this kind of iteratively. So you can expect that to come down. You'll get proposed agendas for subsequent meetings. Dr. Carter, you're right. It's kind of artificial the way we divided up these subject matters, and the human body doesn't fall neatly into those silos. Guilty as charged, but we haven't forgotten your wisdom about, even though we divide the meetings that way, doesn't mean we divide people that way. Point well taken. So you'll be getting draft agendas and more materials for you. That was my magic show. Now and we didn't make as much progress as we thought we would on the states, but it took us a little longer to make progress and come to closure on the Medicare data question. We did. And I appreciate all of you for bringing out concerns, provisos. Those will be taken very seriously. I've got a list of them. My colleagues write better than I do because I was facilitating and writing, and I don't multitask that well. So,
Jack, can we ask before public comment?
Yeah, please. Yeah.
Because we only got to half the agenda today.
Yeah.
And this is really important, and we've got to get these ideas out on the table. I might suggest we now have to amend our next meeting agenda. We had hoped to spend it entirely on the ambulatory side. I think we really need to look at limiting the presentations. We need to hear the ideas from the people around this table. Perhaps one step we can do is asking everybody to turn in your homework, if you don't mind. If you thought you were going to get an opportunity to share your ideas, we got none of those ideas out on the table, and I'm feeling pretty badly, actually, about that. If we don't hear from you, we don't have a good place to start, and I don't want this report to be simply other people's ideas. It needs to be your ideas. We need to create ownership. We need to create buy-in. And so if we could ask you to submit via email your ideas for statewide and regional, and then I think we're going to need to carve some time out of the next meeting agenda to get to this really important discussion.
Yes, thank you, Carmela. I'm sorry, I should have thought to say that. Absolutely. We're not going to just drop this. We didn't get very far on it, but we got some good starts, a few good ideas, and we'll pick it up. Somehow it's on me and my team to figure out how to redo the agenda, advised by Donna and co-chairs, so that we do justice to this, and we'll do that. That's our chore and job, and we'll do it. And I'm going to turn it back to the co-chairs in a second, but I apologize to those of you out there who've been listening. If anybody toward the back of the room has a thought, a comment, a concern, this would be the time to say it. Of course, you can also send something to us, but if anybody wants to make a comment now, we are open to that. Okay, I don't see any. Again, you can contact us if you do. So now it's 1 minute to 12. The only thing I can do right is end on time. But I try to respect people. You're all busy people. We have other meetings. But let me turn it back to Laura and Carmela to see if they have some closing thoughts. You can use it.
So still a lot of work to be done, clearly. We do want to thank you all for your time, and we know this is not an easy approach. And, I come at this from a very different perspective, certainly from the ambulatory side and public health side. And so I'm certainly more interested in the next conversation that we're going to have. But this is really important for public health, for primary care, and certainly for the state of Maryland as it, around the waiver. And the care coordination, not only in the hospital, but I will say that it starts outside the hospital, especially for those individuals that might not fall in the high-risk bucket, but the chronically ill at risk, to really manage those individuals well in a way so they don't touch the hospital in the first place, or we keep them out of touching the hospital for the first time for longer periods of time. And there's lots of moving pieces, but some of this work, it only makes sense to do it at a statewide level and a regional approach because of the movement between hospitals, between providers, the number of primary care providers, and the number of specialists. So I was at a talk once, some of you have heard me said this, and I was at a talk with Jeff Brenner and a colleague of his while he was speaking, said to me, you know what stakeholder meetings are? And I said, no, what? And he goes, it's when everyone drives their stake into the ground and holds on as tight as they can. And this is really our wake-up call, to let go of those stakes and really start thinking in a way that we haven't before, not only for your respective institutions or your respective practices, but certainly for the residents of Maryland that we serve. So I know a lot of tough decisions and thinking about what's going to go in each bucket, but it's really important that we start making some decisions about where some of these things go.
Well, that's it. We did it. It's 12 noon. Thank you. Remember, next meeting February 12th, 2 o'clock.